This is there. Also, another consideration which has to be taken into account is neutropenic patient or the pancytopenic patients. In those patients, you need to take a larger volume of sample and you need to have a bigger reagent cocktail for processing. In neutropenic patients, I'll be discussing in my further slides that you need to establish the LLOD, that is lower limit of detection, which was discussed yesterday as well. So if there is neutropenia, your lower limit of detection, that would decrease. So if you want to detect minor PNH clones, it becomes difficult. So you need to process a larger volume of sample in pancytopenic patients. Plus, this becomes important when you are analyzing monocytes, because the percentage of monocytes in an already pancytopenic patient would be further less. Now coming to the pre-analytical issues. So the most important pre-analytical issue with the PNH is that in PNH you are detecting absence of the cells. Absence of the cells for the GPI-linked protein rather than the presence. Everything we studied yesterday, leukemia, CLPD, in MRD, you are detecting positive cells. For detecting negative cells, your machine setup should be such that your negative population is on the scale. If they are out of the scale, you will be missing out on those populations. So it is very important that your setup plus your compensation are appropriate. Otherwise, you will miss out on your positive PNH findings because you have to detect a negative population. Plus cell viability. We all know with storage and with the longer duration of sample processing time, the cell viability is lost. If cell viability is lost, again, they will be negative for the markers which you want to analyze. So it will lead to interference with your analysis. Another thing is that some of the cells might be dead. So it will lead to aggregation or agglutination. So it can artifactually increase or decrease the expression of antibodies which you want to analyze. So because of that, again, the analysis will be influenced. So to avoid the underestimation or overestimation, you can use a viability dye, that is GRAQ7. It's a fluorescent impermeant dye which does not enter the intact cells. What it does is, it enters the compromised cells and it readily binds to the nuclei to report cell death. So what you get is, for example, here you can see in the upper figure, that is without DRAQ7, in the lower figure it is with DRAQ7, you can see that the debris is much less when you are using a viability dye. So DRAQ7 or any viability dye helps in a better diagnosis of PNH and a more accurate diagnosis of PNH. So what is the need for high sensitivity flow cytometry for detection and monitoring? That is to detect minor PNH clones or less than 1% PNH clones when they are present. So if you want to detect a PNH clone size of 0.01% sensitivity, you need a high sensitivity testing. So it is essential to reliably detect PNH clone sizes of less than 1%, especially in situations like aplastic anemia or MDS. Now, main determinants of sensitivity in any rare event analysis, for example, MRD also, you need to analyze more number of cells. So you need to process a larger number of events to have a rare event analysis, such as the case with high sensitivity analysis of PNH as well. Also, you need to discriminate between the positive and the negative events, which is a very important parameter for PNH, which I have already told you. So, and that is why it makes the analysis more difficult on monocytes. This was a large multi-center study in which it was shown that 42% of the cells, 42% of the PNH positive patients had clone size of less than 1%. So if you do not have high sensitivity analysis of PNH, you are going to miss out on those number of patients. And why is it important to recognize such clones? If it is less than 1%, why is it important to identify them? It is important because they can expand in size. And that is why, like ma'am explained, you need to do retesting in these patients. Because it is possible that they are stable and they are just 0.5% at one point of time, but after 5 years or maybe after 1 year or 10 years, the clone size becomes 90%. So it is very important to, even if you have 10 events of PNH, if they are there, you need to report that. You are not supposed to write they are negative for PNH even if you have a rare event which is positive in the case of aplastic anemia or MDS. So important set of key points. What is important is that you have bi-exponential or logical plots. It is important to ensure that your negative cell population are on scale. For RBCs, it is very important to use unstained RBC population because obviously if you lyse, you will not be able to analyze your RBCs. For WBCs, your internal control, that is lymphocytes, they should be, you have to ensure that they are clearly on scale. Otherwise, your interpretation is going to go haywire. So cell staining protocols, the most important guidelines which are followed in today's scenario are 2018 ICCS or ICCS ESCCA guidelines, which is a fully comprehensive series of multiple papers in which they discuss the clinical conditions, the sample preparation, monoclonal antibody, fluorochromes, analysis, as well as external quality assessment. The basic principle for PNH analysis is any cell type which you want to analyze, first you need to gate that population. On the gated population, you want to see the absence of 2 GPI linked markers. And for RBCs, which I will be discussing, it is usually restricted to 1. But in WBCs, if you are not analyzing 2 GPI linked markers, your analysis might not be correct. Coming to RBC-based flow cytometry detection of PNH, earlier flow cytometry methods, as has already been discussed, primarily relied on CD55 and 59, that is decay accelerating factor and MIRL. However, the sensitivity of those approaches were not good for clone sizes below 1 to 4%. And that is why they were inadequate for detecting minor PNH clones. Additionally, simple routine assays do not employ any specific erythroid marker for the RBC gating, because of which any processing artifact, any platelet aggregates, they would be categorized as negative for RBC, negative for GPI linked marker, so you will consider them as PNH positive. So that is why routine analysis of RBC, historic RBC analysis lacked precision and accuracy. In the ICCS, it was recommended that you need to use an erythroid marker which was CD235A or glycophorin, which is a marker of erythroid lineage. However, the problem with CD235A is that it is present on all RBCs. So now you need to have for establishing a negative and a positive threshold, you need to establish the signal to noise ratio, as was discussed yesterday. Now, if you do not have a negative population, how do you do that? You need to do extensive titration, because with the problem with these antibodies is if you use them at a higher level, it will lead to more aggregation. More aggregation of RBCs will lead to wrong analysis. So you need to titrate it and you need to establish the internal control, the threshold at which you will use your antibodies. Is the concept clear? So careful titration of CD235 antibodies is of paramount importance when you are doing PNH analysis for RBCs. Now coming to antibodies to GPI linked structures on the RBCs, historically we have already told you it was CD55 and 59. However, extensive assessment of CD59 and 55 has indicated that properly validated conjugates of CD59 best delineate between the type 3 and type 2 RBCs, that is between the complete deficiency and the partial deficiency. Also, dim staining with CD55 can be misleading. That is why what is now recommended is that you use CD235A FITC for gating and CD59PE for your as a GPI link marker for the RBC analysis. Coming to the acquisition and analysis part, for GPI deficient RBC clones, you do not have to do a lysis step because you want to analyze your RBCs. CD235A is for the gating and 59 is for GPI deficiency. For RBC analysis, you need to have log versus log displays because obviously your number of RBC is very high. And also it is easier to exclude debris, especially platelet debris. And it is important that log or log to log display also rules out your significant aggregation. And it is also noted that collection of as few as 5,000 RBCs are able to detect 1% of the PNH cells. So when initially establishing an RBC assay, type 3 gate is positioned using cells stained only with CD235A. That is to establish your first gate, that is to detect your type 3 NRBCs. You want a tight gate, so you are using just CD235A, that is the gating marker for RBCs. And the next plot you establish for the type 2 population, that is done with approximate location of the upper limit of the type 2 region, which is determined by a normal sample stained with CD235 and CD59. So these are the graphs. So this is the normal time versus site scatter. Here you are seeing you are ruling out any debris or you are just seeing that the acquisition is normal. Once you have that, you remove your debris and you acquire your RBCs. When you gate with CD235A, the aggregation of the RBCs you can remove by seeing where is the higher site scatter. Once that is done, you see the type of RBCs which you have. So what is this population of RBCs? Yes, and type 1 are normal. So this is a normal pattern of RBC acquisition in the normal sample where there are no RBC clones. And it always helps to have a histogram. Here you can clearly see that this is just type 1 RBCs, and type 2 and type 3 type of RBCs are not there. In the second graph here, we can clearly see that the RBC population are falling into 3 groups, that is type 1, type 2 and type 3. Type 3 are the ones which have complete deficiency of the GPI linked proteins, type 2 are the partial deficiency ones, and type 1 are the normal RBCs. Coming to the reporting of RBC, this will be discussed more in detail when I talk about the reporting of WBC. But for RBCs, the most important part is that both the percentage and the proportion of type 2 and type 3 RBCs must be reported. And it is significantly better at demonstrating partial antigen deficiency, as has already been discussed by Mrinalini ma'am. The monitoring of RBC PNH clones is very important if the patient is on therapy. The therapy is eculizumab, which is a monoclonal antibody which inhibits the complement lysis. If complement lysis is not happening, what will happen? The RBC clone size is likely to increase or decrease. It will increase because now the RBCs which are deficient for the GPI linked proteins are not getting lysed, so will be coming up in your analysis. So for the monitoring, it is very important to have your RBC parameters as well. Now coming to WBC based flow cytometry detection of PNH. So why do you need WBC based testing? It is needed because RBC clone sizes may be not representative either because of hemolysis or because of transfusion reaction. Plus, size of the neutrophil clone is more relevant to the thrombosis risk in the classical PNH patient. And the measurement of neutrophil and monocyte clone percentages, they better reflect the size of the PNH clones. It is widely recognized as the best method, and lymphocytes, I have already told you, are not suitable targets because of 1, their long half-lives, 2, the expression of the GPI linked proteins is not very consistent in lymphocytes. But what is the importance of lymphocytes? They are very important as the internal control. They should be fully on scale and they should be representative when you are doing the analysis of WBCs for PNH. Historically, ma'am has already told you there have been multiple markers and multiple studies which have been done for the PNH. Various GPI linked proteins have been used for the analysis of WBC. The most important amongst them was 2010 paper, that was Borowitz, and the latest has been ICCS and European Society of Clinical Cell Analysis, that came in 2018. Now, as per 2018 ICCS guidelines, 2 GPI linked structures need to be analyzed on WBCs. And the most validated combination for neutrophils is FLAIR in combination with CD24 or 157. For monocytes, it is FLAIR in combination with CD14 or CD157. Now, why do you need 2 GPI-linked markers? This is to prevent false positive reporting of PNH. As ma'am has already said, if you are using just one GPI-linked marker and your position is not correct, for example, if there is a granulocyte gate and some monocytes are there, so they will be negative for CD24, they will be negative for CD15, and you will interpret them as negative for PNH in a neutrophil gate. So you don't want to do that. You want to establish a high accuracy test, and that is why it is mandatory that you analyze 2 parameters. And you always have the gating markers specific for the cells which you are analyzing. So the gating marker CD45 obviously you have to incorporate, which is recommended as a part of any gating strategy to identify the specific subset of leukocytes. CD15 is recommended for neutrophil gating, 64 is recommended for monocyte gating. CD33 was previously recommended, but it is difficult to have CD33, especially in MDS cases if you have blast, and they can interfere and have a negative population when there are basophils in your peripheral smear. So GPI-linked reagents for the neutrophils and monocytes. What is FLAIR? FLAIR is fluorescent labeled aerolysin, which is a highly specific ligand for GPI anchor proteins on the WBCs. Inactivated non-toxic conjugated molecular variant of FLAIR has been developed. It's a Alexa 488 conjugate, which has been standardized and validated for the WBC experiments. FLAIR binds specifically to the GPI-linked protein. So if a cell does not have a GPI-linked protein, FLAIR will not be there, and that is why it has become a most commonly used marker for the WBC analysis. Now, can FLAIR be used for the RBCs? No. Why? Because RBCs express glycophorin A, which is a non-GPI linked protein, but can weakly bind aerolysin. So if you are using FLAIR in RBC analysis, it will interpret with your diagnosis. So CD24, I've already told you, is the more specific marker for testing neutrophils for GPI deficiency. 14 is a more specific marker for monocytes, although it can have a problem when there are dendritic cells in the basophils, and that is why it is always recommended to use CD14 with another GPI-linked marker, which is FLAIR. Now CD157 is the latest marker, which is brightly expressed on both neutrophils and monocytes, and now it has almost replaced CD24 and 14 and used as a single antibody for detecting the GPI-linked deficiency for both monocytes and your granulocytes. So these are the validated antibody mixtures recommended by ICCI guidelines for both BD and Beckman-Coulter machines. Our panel includes CD45 for gating, 15 for neutrophils, 33 for monocytes. However, as of now, you should not be using CD33, but you should be using CD64. And 24, 14, and FLAIR we use as the GPI-linked proteins. So here, you can clearly see, this is my first plot where I am ruling out the debris. When you have removed the debris, you gate the cells with CD45. Then you do gating for the neutrophils with CD15. When you have it, you gate the cells with CD24 and FLAIR. So you can clearly see a population of cells which is PNH positive. For the monocytes, you do your gating with CD64, and then you gate those cells with CD14 and FLAIR. And anything which is double negative for FLAIR and 14 are your PNH population. This is a 5-colored flow cytometry with CD157. The principle remains the same. You rule out your debris, you gate your lymphocytes with CD45, and then you do gating with CD15 for the neutrophils and CD64 for monocytes, and then you do analysis with 157 versus FLAIR for both the respective population of cells. Okay. Coming to type 2 cells in neutrophils and monocytes, Sometimes you can have type 2 cells like in RBCs in neutrophils and monocytes as well. However, you do not need to demonstrate them every time. Plus, there have not been consensus guidelines regarding reporting of type 2 cells in WBCs. Comparing the clone size between neutrophils and monocytes, sometimes there is an agreement between the clone size of monocytes and neutrophils, but many a times there is a sharp variation. And usually the clone size of the monocytes are much larger than what you have in the neutrophils. The reason for this is unclear. However, possible factors include infections, different lifespans, and selective loss. But the important thing is that you do analysis on both the monocytes and the granulocytes. Reporting, you have to list all the gating and the diagnostic markers. You are supposed to mention the LLOQ, that is lower limit of quantification, as well as LOD, that is limit of detection for your lab, because without that you cannot justify what is the sensitivity of your lab. Also, if recommended LLOQ for RBCs is almost 0.05%. For WBC, it is 0.1% or better for neutrophils. If it is 1%, that means you are missing out on the minor PNH clone which might be present in the patient. Report if a PNH clone is present or absent, preferably on both monocytes and the neutrophils. Interpretive terminology includes if they are more than 1%, it is PNH clone. If it is between 0.1 to 1%, it is minor PNH clone. If it is 0.1%, then also you are supposed to report them, and you can report as rare cells with GPI deficiency or rare cells with PNH phenotype. If there are fewer CD15 neutrophils, like already stated, you should state the change in the LLOQ and the LOD, and you should state that a minor population below the limit of detection cannot be ruled out. So retesting, as ma'am has already explained, is important in the patients of aplastic anemia and MDS. So the take-home messages include RBC PNH estimation is better to detect partial antigen deficiency. WBC is a better method. Negative rather than the positive population needs to be established, so your voltage setup and compensation need to be in place. High sensitivity testing is required for minor PNH clones, and FLAIR is a very important reagent for detecting the GPI deficiency in WBCs. These are the references.
That was a very lucid, very informative talk. I hope all the PGs will be greatly benefited by that. Any queries from anybody?
I just have a comment that the drug that you told, eculizumab, it's very costly drug,
yes,
and beyond the range of most of the Indians.
Yes, sir.
Before I hand over the mic to Dr. Pati for his final comments, these are conceptual. The first part was concept, the second part was flow. So have you really wondered why we are not involving platelets in PNH studies? I mean, why this favoritism? RBCs kar rahe hain, WBC kar rahe hain. Why this favoritism? Platelet clones are also involved in thrombosis. Think कि हम लोग platelet क्यों नहीं कर रहे? So this is very important because of the variable sensitivity to complement lysis of platelets. It's difficult to identify the complement lysis in platelets, and also the platelet clones are extremely small for detection. Dr. Pati sir, in 1997, Diamed India had come, and we had set up the gel card test. One of the beautiful tests in PNH, Dr. Bindra has also set up. So gel card test was such a beautiful test for RBC clones. And it was almost 75 to 90% sensitive and 100% specific. Why suddenly the gel card has disappeared and flow has come for that fantastic glycophorin A in flow cytometer? It was so inexpensive, so wonderful. We actually standardized it, and we give this in the MD examination. अगर तुम्हें agglutination मिल रहा है, इसका मतलब क्या है? अगर एग्लूशन नहीं मिल रहा है इसका मतलब क्या है? हाउ डू डिटेक्ट पीएनएच इन जेल कार्ड वर्सेस ऑटोइम्यून हेमोलिटिक एनीमिया डीसीटी पॉजिटिव? ठीक ऑपोजिट. Remember, we give this in spot. So suddenly the gel card has disappeared and flow has come. Why? So this is the important thing. Platelets, remember, we don't do it. Dr. Shilpi and Dr. Minal is going to do the live gating, and you'll understand this because it was so difficult to standardize this PNS test. I hand over the mic to Dr. Pati for his final comments. No, Dr. Pati. Yeah. I'm amazed. The reason it has disappeared is gel card is unable to detect type 1, the smaller clones of PNH, which the flow is detecting. That is the reason.
And now they've stopped manufacturing that.
Yeah, diamond is gone. It came from Egypt, So what I'm trying to say is, it is still one of the very, very good techniques, and you should have it in your blood bank. So, Pati sir, I request you for a comment.
I think first to start with the gel card, I think that now some of the application of flow cytometry, the quantitation has come as important issue, like whether we call CD4 count, CD3 count, or the PNA cell count. So that number is important. Even the smallest number of positivity, PNS cell presence, like in aplastic anemia, as therapeutic evidence is proven. So I think that is probably the reason. The gel card is just a positive and negative. So it's just presence.
Not
it is
a
not.
high
So
sensitivity.
quantitation is important. Some of the, unlike the acute leukemia, the quantity is not important. We have to just say that the clonality, present or absent. That's what it is. That's what. I have two queries to start with. That in PNH. Because we are doing all the granulocytes, but granulocytes and monocyte. Is it really clinically any relevance to continue with RBC flow cytometry? This is one question. You can answer that. My second point is about the RBC. We are talking of the type 1, type 2, type 3. My hunch is, though I don't have the answer, but my hunch is it is a historical thing is that we are just carrying it forward without want to give it away. We are not throwing it to dustbin. That is what I think my mind it is there. It has no something like a very double-blind study or very authentic study has shown that what exactly relevance of that. Like this is my belief that a red cell which will be either completely hemolyzed or not hemolyzed. There can't be partial hemolysis. So same thing also, if it is a partially presence of the anchor proteins are there, it won't get the complement activation won't occur. To its complete, the classical activation won't occur and it won't be hemolyzed. So why you are just latching to it for no reason? That's what my concept. The first question I want an answer as an expert from you.
So very good questions. So RBC analysis is still recommended because one is the partial deficiency, and that is your second question, that is true. But when there are different in the clone sizes and you follow up the patients, it is easier to establish the correlation between the RBCs and the WBCs. Like when the patient is on any therapy. So initially there will be no correlation, but when you have a matching population of PNH and WBCs as well as in RBCs, it gives more confidence to the clinician. Latest literature says this thing only because nowadays there are many institutions who are not doing RBC. We are also not doing RBCs at present. We are primarily doing WBCs. But the latest guidelines of RBC they are suggesting you include CD71 in your gating. Because CD71, what it does is it stains the immature RBCs as well. And those are not susceptible to hemolysis. Because of that, you are able to pick up the RBCs which are not hemolyzed, and your clone size for RBCs and the WBC, they will be matching. So,
Just for information, CD71 is trans-erythroid, and that actually detects. Fair enough, but Dr. Pati's comment is actually very, very valid. But it's the second one.
yes, sir.
Chalo.
Thank you. Thank you, everyone.
Thank you, ma'am, for that very wonderful talk. May I now request Dr. Colonel M.S. Pindra to please felicitate our guest speaker, Dr. Mrinalini Kotru.
May I now request the chairpersons to also felicitate Dr. Shilpi Moore. I would also like to add that ma'am has put her heart and soul to this conference. She has worked tirelessly day and night to make this conference a success. Please give a huge round of applause for Shilpi ma'am.
May I now request our chairperson, Dr. Mukta Pujani, to felicitate our other chairperson, Dr. Colonel M.S. Pindra. May we now request everyone to please proceed for high tea. We hope you enjoy the refreshments and return rejuvenated for the upcoming session.
काम करते हैं अभी क्या
सुनो मैम का ना फोन लगा है बस बड़ा है कोई चुराने पाएगा नहीं
ठीक है ना
हाँ मैम
हम तो नहीं अच्छा अगर ले चलो तो बेटर होगा
अरे कॉल नहीं जाएगा वो पड़ा तो है
ले चलो हम बाद में कनेक्ट कर देना वापस आके हम बेटर रहेगा थैंक यू हाँ बहुत अच्छे बहुत अच्छे
समझ में आया
बड़ी डिफरेंस
सब मीठा चौदह और मीठा चौदह बच्चे नहीं खाई
मैम शिल्पी मैम क्या करे गरिमा एक बार SRPG रूम में मैम भी कह रही मुझे एक बार मैम के रूम में और SRPG रूम में देख पाते हैं चलती मेरे को
यहाँ पे जो सिलिका थी
इन दोनों को यहाँ छोड़ते हैं अपन डिपार्टमेंट होके आते हैं दोनों
यहाँ पे जो सिलिका था उस दिन कौन सा बॉक्स आया था इधर? उस दिन तो सब स्लाइड लगा के देख
कौन सी ट्रे आई मुझे नहीं पता मेरी अलग ट्रे थी मुझे बस उसका पता है आज जिनका सेशन है या तो उनसे पूछ लो ना आज PNH का सेशन है नेहा गर्ग से पूछो नेहा गर्ग से पूछो हो सकता है उनके साथ ही मोटी स्लाइड मिल नहीं रही है हो गई कह रहे हैं कि स्लाइड बॉक्स हमारे पास नहीं है
रिहर्सल वाले दिन सबमिट कराई थी हमने, तो यहाँ पे हमने देखी भी थी।
डॉक्टर अंकिता आप भी चलिए डिपार्टमेंट में हम लोग देखते हुए चलते हैं कहाँ देखेंगे डिपार्टमेंट
मैम रिहर्सल वाले दिन जो बॉक्स आया था वो पता है?
रिहर्सल वाले दिन
यहाँ
क्या
पे-
लिखा हुआ था स्लाइड्स के ऊपर क्या नाम कुछ लिख रहा
मैं पूछ लेता हूँ।
यार आप ना हमारे पीजी से कांटेक्ट करो, वो देखो उधर हॉल में है ना, उनसे बात करिए।
हम उस दिन
पीजी नहीं तो मैं बात करूँगी मुझे बताओ स्लाइड के ऊपर क्या लिखा है
पूछ लेता हूँ, तुमने स्लाइड देखी है?
हम देखिए स्लाइड बनवाई नेहा ने। मैंने स्लाइड देखी है माइक्रोस्कोप में, स्लाइड पे लिखा था क्या?
एक बात बताओ, स्लाइड बन भी सकती है अगर तुम थोड़ा क्विक करो, हमें सैंपल बता दो, स्लाइड बनाकर अभी स्टेन करा के निकलवाते हैं।
अरे तो वो उसकी वाली स्लाइड का जुगाड़ हो सकता है।
एक बार डिपार्टमेंट देखते हुए चल रहे ये फोन कर जो है लगता भी नहीं है दिस इज अ गुड मूवी
वो
हमारे पास बहुत सारे ना वो जो
स्लाइड
चले एक बार डिपार्टमेंट को चलते हैं
पोस्ट रंजित लिखा हुआ है।
क्या लिखा हुआ?
पोस्ट रंजित
पोस्ट रंजीत और सेकंड पे
एक ही है हमारे।
अच्छा एक ही है ठीक है
और कोई स्लाइड्स है इसकी, कुछ डुप्लीकेट्स बनी हो, कुछ पता
डुप्लीकेट्स
हो?
के लिए पता कर रहा हूँ।
पता करो जल्दी। ठीक है सर?
क्या हुआ? हाँ। बिल कर रही है, उसने सबमिट करवाया था।
एक मिनट रुक जाओ, उधर से वो कौन सा नहीं नहीं, मैम को चेक करवा लो।
मैंने 2 बार सेंड किया, आई डोंट नो
हाँ मैम,
व्हिच
ये
वन।
फाइनल वाला है, आप एक बार चेक कर लीजिए।
लास्ट ठीक था।
मैम उस पे
Visibility?
हाँ मैम, वो लाइट हम ऑफ कर रहे हैं।
अच्छा, अगर प्लॉट्स में कुछ वो करना है, अच्छा यू हैव दीज ना पॉइंटर्स एंड दिस इज द वे।
यस मैम, दिस इज द पॉइंटर।
सो ये दोनों ही अपने वो है ना? ओके फाइन, वो लग नहीं रहा था मुझे कि विजिबल होगा, नाउ इट इज़ विजिबल। ठीक है फाइन, ठीक है, थैंक यू।
नहीं मैम, यस मैम।
फोटो सेशन अभी मौका लगा इधर। चल रहा है
एक सामने और एक इसमें नीचे देखते हुए। एक और खींच। मेरा फोन करना चाहिए। मेरे पास भेज दिया।
क्या हो गया मानसिक, क्या हो गया?
चलो तुम दोनों ब्रेकफास्ट करके आ जाना, फिर मैं चली जाऊंगी।
दो दिन ज़्यादा होगी क्या? तो ये खुद कर लेंगे, खुद ही कर लेंगे छोटे वाले।
वो अभी आएंगे को इधर ही बिठाना है, ये चेयर पर से जुगल करके
Just ask them to give the fresh water.
Hello, everybody. I hope everyone is refreshed and rejuvenated after that high tea. We'll be starting with the next session in 3 to 4 minutes. I request everyone to please come back to the hall for the next session. Hello, everyone. Our next session is on the concepts of lymphocyte subsets in hematopathology and flow cytometry-based lymphocyte subset panel designing in primary immunodeficiency disorders. And to chair the session, I now request Dr. Shailja Shukla, Director Professor, Department of Pathology. Dr. Shukla's name needs no introduction in the field of pathology. In her distinguished career, in addition to the conventional methods of reporting, she has also worked extensively in the field of biotechnology. Ma'am is a prolific author with over 90 publications in national and international journals. She is a former treasurer of Delhi Society of Hematology and also a member of several scientific bodies, including member of Board of Specialists in the specialty of pathology in the National Board of Examinations. Please give a big hand for Dr. Shailja Shukla.
To chair this session alongside ma'am, may I also introduce Dr. Vijay Kumar, Professor and Head, Department of Hematology and Clinical Pathology, RML Hospital, New Delhi. Sir has extensive experience in hematology for past 23 years and has published over 85 research papers in various esteemed national and international journals. He is a member of numerous esteemed expert committees, including NBE, NMC, and UPSC. He is also one of the core expert team members to get accreditation of NMC by World Federation of Medical Education. Sir is also an expert for ICMR Task Force on establishment of reference intervals in Indian population. Sir is a contributor of PGI textbook of Lab and Clinical Hematology, and Sir has been honored with the Best Postgraduate Teacher Award, J.C. Patel Award, and Pratibha Samman Award. So please welcome Sir with a huge round of applause.
May I now request Dr. Shailja Shukla to introduce our first speaker, Dr. Prerna Arora.
Dr. Prerna Arora is an alumnus of MAMC, and then she went on for her training in AIMS, and she's now working as a professor in the Department of Pathology in Maulana Azad Medical College, and she has interest in the whole of hematology. I should say, and she's got a very keen interest, especially in benign hematology, which will be talking about today, the lymphocyte subsets. And when the lymphocyte subsets comes into mind, what we think are of the inherited disorders of immunity, the primary immunodeficiency diseases. But the lymphocyte subset typing can also be helpful in many acquired conditions also, like autoimmune hemolytic anemias, on which she's going to talk about today. So over to you, Dr. Prerna, for your talk on the lymphocyte subsets.
So thank you, ma'am, for the kind introduction. And at the outset, I would like to thank Dr. Tathagat sir, Dr. Mukta ma'am, and the entire organizing team for giving me this kind invite for this prestigious event. And I must congratulate them for bringing out such a huge turnover. So I think that's really remarkable to have this workshop, and with so many number of the residents who are going to gain so much knowledge from all the things which we are now doing practically. So without further delay, I would like to take you the journey of the lymphocyte subsets. It's not highlighted here in the screen. Okay. So the concept of lymphocyte subsets in hematopathology, as ma'am rightly said, so the large portion of lymphocyte subsets which you are doing in primary immunodeficiency, but there are other aspects also where we utilize lymphocyte subsets. In fact, when we see hematology and immunology, now practically every part of the hematology, immunology, we are using these lymphocyte subsets for the analysis. So these are lymphocytes. So the name is lymphocytes, but yet what do we see here? So we see the different forms of the lymphocytes. So some of them are the undifferentiated blasts, some of them could be just activated lymphoid cells, some of them will be large granular, and these could be caesary cells. So the same cells, but yet the different stages of differentiation, the different the markers of the activation which are there on them. So these lymphocytes, they are having very diverse microscopic appearance and divergent development, and are functionally heterogeneous. So certainly it's not easy to say them which of them is B, T, or which of them is CD4, CD8. So that's why it's pertinent to have a system where we can categorize these subsets in various disorders. So this will be the layout of my talk, a brief about the components of the immune system, because ultimately what are we dealing with? The lymphocytes, then how the B lymphocyte develop, the T lymphocytes, their markers and their uses in various hematological disorders, and the sample processing, which is a very pertinent part to come to the conclusion about the lymphocyte subsets. So we are all aware of the immune system, the immunity. So the mainly B lymphocytes and T lymphocytes are part of adaptive immunity, and the innate comprises of the epithelial barriers, NK cells and dendritic cells. So what is peculiar of the immune system is that they have specific markers or receptors on the surface which will help them in their identification. So B cells, we have immunoglobulin, T cell, we have T cell receptors, and they are also very important because they have a specificity. That is, they will respond only to the when they are encountering a certain type of antigen or certain. More important, have that they can recognize what antigen exposure they had, and they will be activated in certain diseases. So another way to looking at is the humoral and the cellular. We all know humoral is by the B cell, which ultimately produce plasma cells and the antibodies, while cell mediated is mainly the part of the T lymphocytes. So the insight of this important diagram, which is taken from WHO, is very important once we are dealing with the B lymphocyte subsets. For example, the B cells, as the name derived, they are from bone marrow. Progenitor cells, immature B cell, now some of them will go apoptosis, while some of them will come into the peripheral circulation where they will mature in the peripheral lymphoid tissues, like we have lymph nodes, spleen, and these naive cells means they are not. So some of these will localize in the follicular, and some of them will go into the germinal center where they will go through centrocytes, and ultimately they will form plasma cells in the antibodies, and some of these cells will become the memory B cells. So I want you to remember these memory B cells. Like the name suggests, you should also memorize them because they are an important subset of B lymphocytes. Now this insight actually gives us the their differentiation of the various malignancies, but I will not be covering because this has been covered yesterday also. So as they go through the various stages, they do develop their certain set of markers which will be highlighted by their, so that we know that at what stage they are, what of the cells we are dealing with. For example, CD10 switches over early, but then again it comes over in the germinal center. So now we are dealing with the subsets of germinal center. We know that it is a mature lymphocyte and expressing CD10, we are dealing with the germinal central component. So on and so forth. So not going into the further details. So again, these are the immature precursors which I will not be talking about. So we have antigen unexperienced, that is the naive cells. So naive cells have various components like transitional, naive, mature, and of course we have memory cells, and memory cells also have various subsets. So but the major lymphocyte subsets, when we categorize them, as we have B1B cells and we have B2B cells. Now it is the B2B cells which we find majority of the portion of circulating in the blood as 65 to 90% as marginal zone and the follicular cells. Now here you can see there are the B regulatory cells. So as the name itself suggests, they are going to regulate something. So they are important component when we are dealing with the immune disorders, be it autoimmune, allergy, infections, malignancies, and now a lot of search is being done on this component of the B lymphocytes. Now we have B1B cells, as you can see we have CD5 positive B cells. So CD5 is conventionally a marker of which T lymphocytes, but here these B1 A cells, they are showing CD5 and they are involved in which malignancy, like you heard yesterday also a lot about it, CLPD, CLL, mental cell, right? So they component normally they circulate only in 5 to 30% or maybe less. So it's important to know that these cells are a part of the normal peripheral blood also, but yes, they are seen in specialized tissues like spleen, like an umbilical cord. If you will do the lymphocyte analysis, you will find a lot of B1A or CD5 positive B cells in circulation. So that does not mean umbilical cord has CLL, right? So that is the whole concept of knowing why you have to know the subsets and markers and where and when they are expressed. Similarly, we have T lymphocytes. So what is T? T stands for thymus, very good. So the progenitor do occur in bone marrow, then their further subsequent maturation, activation is taking place in the thymus. So what we have is the cortical lymphocytes or the cortical thymocytes. Now the cortical lymphocytes, they mature into alpha beta or they can be gamma delta. So this you will be hearing quite often, and I want specifically you to remember the gamma delta T cells. So what is happening here? These cells are going into the circulation, but what is happening to alpha beta? They are developing which marker? CD4 and CD8. So when these gamma delta cells move out, they are devoid of any CD4 and CD8. Okay, so please remember this point when we will discuss the subsequent cases. So these cells are particularly important and they localize in certain specialized tissue like spleen, peripheral blood, intestinal mucosa, right? Now these T lymphocytes alpha beta, once they go into the circulation, these are naive. So naive means they are not experienced, they have not encountered any antigen. But what happens when they encounter antigen? These lymphocyte subsets will undergo under the effect of various cytokines, they will develop into helper cells. Some of them will become a T regulatory cells. Again, as the name suggests, they are going to regulate or they are going to suppress the immune system. And some of these lymphocytes, very cleverly, they will go and sit into the follicle and they become in the follicular dendritic cells, they will be as T follicular helper cells. So as the name suggests, you are done with your lymphocyte subsets. We have T, total T, we have cortical T, we have gamma delta, we have alpha beta, we have various CD4, we have T regulatory cells, we have T follicular helper cells. So again, this is important because of categorization of various malignancies, because they recapitulate their stages of differentiation. So again, the same Not going into the detail of the precursor cells because yesterday was covered. Now see again T follicular helper cells. So CD10 has switched over very early. But if you see it here again, T follicular helper cells are expressing CD10. So now when I am analyzing the lymphocyte subset, I am finding these are the mature T cells, but yet they are having CD10. So I know they are coming from where they are coming from. And also if you see, so which was the marker in B lymphocyte which was throughout present, right from the beginning? CD19, very good. So here what is the marker here? CD7. So as you can see in CD3, it is a cytoplasmic CD3 which will switch over at the cortical thymocyte. But it is a surface CD3 which is going to come, and also the mature T cells will have either CD4 or CD8. That's why it is not clubbed out here, right? So when I see mature T cells, I know they will be surface CD3 positive, they will be CD7 positive, and either of them will be either CD4 or CD8. So if I am finding abnormality that yes, this T lymphocyte is not showing CD8 expression but CD4, so they could be CD4 and other could be CD8. So this also, please remember this chart again, we will be discussing in the various cases that will be seen. So T lymphocytes with the help of various cytokines, this I have already covered, cytotoxic, the helper T cells with CD4, and again the regulatory T cells, and there are various subsets, not going into the detail of these cells. So when we talk about lymphocyte subsets, we mean to say it is the relative, that is a percentage, and the absolute count of T, B and NK cells. But having said that, you should know what are the various other subsets besides B lymphocytes. We are seeing the naive cells, we are seeing the memory cells, switched, unswitched. More of this will be covered by my colleague in when we are discussing about the primary immunodeficiencies, then B regulatory cells. Similarly, we have total T, naive T, memory T, helper, cytotoxic, and again these components which I have already told you. Now the double negative T cells, like I have told you, mature T cells will have either CD4 or CD8, but these are the cells which are both negative for CD4 and CD8. So the journey actually started much early when we utilized this John L. Fahey, he utilized the importance of CD4, and this was used as a marker for HIV/AIDS. And now this since 1968 this discovery, and now today time also we are using these CD4 lymphocyte subsets in HIV/B when we have to determine which HIV patient is more prone to opportunistic infection or when to start the ART therapy. We are still using this, and this is also one of the defining criteria of the AIDS defining condition. So since then many studies have been done in COVID. Now latest article, this was done in autoimmune vasculitis also. So maybe as I am speaking, maybe some other lymphocyte subset is being discovered in some other disorder, we do not know. So that is the impact of the lymphocyte subset. So I will categorize B lymphocyte subsets into malignant disorders, the utility, ALL and CLL we have talked about yesterday. Now in benign disorders, a large chunk, like I have told you, much more studies in the primary immunodeficiency disorders, which will be covered in the subsequent talk. Then monitoring rituximab therapy will come to this, and then the B regulatory subsets in the autoimmune disorders. Similarly, when we talk about T lymphocytes, we have malignant disorders and large number of benign disorders again like CD4 monitoring in HIV, primary immunodeficiency. Now we are analyzing the T cell subsets in lymphocytic hypereosinophilic syndrome and HLH, hemophagocytic lymphohistiocytosis. Again these subsets in various immune disorders, and double negative T cells in the ELF syndrome, which is the autoimmune lymphoproliferative syndrome. Okay, so before we begin with the lymphocytes, let's see where in flow we are analyzing the lymphocyte population. So this was already told yesterday in number of slides, the where do the lymphocytes lie. So this is CD45 and site scatter. So they have a bright CD45 and low site scatter. So this we call as a lymphocytic gate. But having said that, should we forget our neighbors? Should we be kind enough to remember our neighbors? Yes or no? So your preferences are different. Maybe some are saying yes, some are not giving me an answer. So yes, we should be knowing our neighbors. So this is which gate? Mostly cells come monocyte. This could be the region of blast, right? And what are these? Remember Vidya Balanov yesterday, what we used to see here? Dimmer CD45 showing maturation pattern. I still remember by Vidya Balan, so I am going to remember these cells by Vidya Balan now. Hematogones, right? And here lies the RBCs, debris and the platelets. So we should remember, yes, we should be kind enough to know our neighbors, because sometimes this is a common pitfall when we analyze in the flow machines in our hospitals in these settings. So some of the lymphocytes may go up there, some of them will be mixing here. So you should know these cells in which the lymphocytes can also go and mingle with. So when we talk about B and T lymphocytes, so if I get CD19 here versus site scatter, I have highlighted the CD19. So here what you are finding is B lymphocytes have a slighter dimmer CD45 as compared to T cells. Now why this is so important to know? Because if you are putting a gate and you are seeing only the brightest CD45 and slightly dimmer cells you are not included, so you are likely going to miss the CD19 B lymphocytes in your analysis. So apart from lymphocytes, you should also remember that in the lymphocytic gate, what are the various entities which come in the lymphocyte gate, like mainly they are the mature lymphomas. And as far as NK cells are concerned, so we find CD3, CD19 negative, which are likely to be NK cells, and where they are lying, can you see this, where they are lying? As compared to lymphocytes, they are slightly higher up because they are granulated cells, so they have a little higher site scatter is there. And this we are going to refine in various subsequent gates. So just a brief about the sample preparation. Now EDTA is usually recommended. Why? Because we are not just seeing the lymphocyte percentage or the absolute. We also have to do the differential count. We have to see neutrophils. We have to see monocytes. We have to see other population in totality, right? So in that case, if you have to see the entire thing, EDTA is not EDTA is recommended and certainly not heparin. And specimen transportation is at their room temperature. Now there are two major platforms which we'll be talking about, that is the dual platform and the single platform. So dual, as the name suggests, so there are two platforms. So we can use the hematology analyzer, whatever analyzer you are using, we can calculate the total lymphocyte count from your analyzer, and then we can see the subsets by flow cytometry like CD4, CD8, and we combine the TLC which we have taken from the analyzer and percentages from the flow cytometry, and we combine and we give the absolute count. So that is a dual platform, but the more better method is to use a single platform. So as we name suggests single, that means we are using only one equipment, that is flow cytometry, and flow cytometry, that is all is needed to know the absolute lymphocyte count. So in this method, but we have to use a pellet which contains a known quantity of fluorescent beads. Now these beads are defined by the manufacturer, so we have to put exactly the same quantity of blood which is defined by the manufacturer. And what is the utility of this? Utility is this, that we don't have to depend upon the hematology analyzer. So different labs will have different values because the hematology analyzer is different. Their percentages on flow is different. But if we use a standardized method of beads, that is going to give you the absolute count without any interference by the other instrument and the assays. So this is how, I will not be going into the detail because they will be covered in the next talk. So this is the beads which we are using by the manufacturer, and the bead count is defined by the manufacturer. And what we do is we see the absolute count by total number of bead divided by the bead count you have obtained and your lymphocyte subset we have used. So this improves markedly the assay performance. As you can see, we have to rely only on one machine with the company manufacturer beads which we are using. So sample processing steps are stain, lyse, no wash, and stain, lyse, wash. Now in flow cytometry, you have to make yourself aware by what are the methods we are processing. But just a little bit worried about the stain, lyse, we are not using washings here. Why? Because here what we are using beads. So if you are using bead method, you should always follow stain, lyse, no wash. Stain means you are putting antibodies, you are lysing the solution, and then immediately you are acquiring. So certain steps which are very important, that is the method of reverse pipetting, which we will be telling you in the workshop in the afternoon. Vortex gently, because you don't want your beads to disintegrate, which will give you the erroneous values of the lymphocyte. And the other method we normally follow in the labs is that antibodies, we put lysing solution, and we washing and do this. Now again, we have talked much about the lower limit of quantification. So if you are using bead, a minimum of 1000 events needs to be collected, and the lymphocyte event should be 5000 to 10,000. That is the usual, is the recommended. Now why this high number of lymphocyte event is required when we are seeing lymphocyte subsets? Because you want to be sure that even if there are minimal number of B lymphocytes, you are not missing on them, because that is very important to the patient who is receiving the rituximab therapy. Because if you are reporting as the lymphocytes, B lymphocytes present, that means the rituximab either has not worked or the clinician has to modify the treatment accordingly. So that's why it's important that you should analyze large number of lymphocytes to detect even the smallest quantity of your B lymphocyte. So gating strategy, so this we have talked about, we can gate as per whatever convenient to you or your lab, that is CD45 and side scatter. So here you using lymphocyte, or you can use a forward scatter, side scatter channel where the lymphocytes show low forward side scatter as well as low side scatter. So once we have taken out the lymphocytes, we see CD19, CD3, split the lymphocytes into two populations. Now which component you want to study? You want to study T cell further, you put CD3, CD4, that will give you the helper cells, CD3, CD8, CD8 cells, and then CD16 and 56, that will be the proportion of the NK cells. Now gate purity correction, okay, so gate purity correction is, now I have told you there are interfering factors, like your neighbors might interfere in this, monocytes may come up, then you have RBC debris, unlike RBCs or any platelets, they might interfere. So here in certain cases you have to be very discreet and to yourself, mind your own business. I don't want any monocyte to interfere in my analysis, so I can put CD14, which will exclude my monocytes, contaminating cells, and what I get is a pure lymphocyte population. So we have excluded. So this plot you will find very often in your labs, okay. So where the monocytes, some lymphocytes will go in the mono will come into the lympho. That's why it's important that you should segregate out the monocyte. So that's why this name has been termed as a gate purity correction gate, which is there. NK cells are simple. NK cells, when we find CD3, 19 and CD3, we exclude. What are the NK cells? Now here we have used CD16 and 56. Now the guideline says it's important to use CD16. Why not only 56? Because CD16 gives a very brighter expression of NK cells and 56 are usually dim. So if you are using only 56 in the NK cell population, it may happen that the dim CD56 are excluded from your, the NK cells might get excluded from the analysis, which we don't want. So the preferred method according to CLSI is use CD45 site scatter gating and use CD16 if you have to see NK cells. But other guidelines do not recommend any particular method, so you can choose whatever method you want to know. Now the most important lymphocyte subsets is the result that we see. So here you can see we have mentioned percentage and the absolute count, but should always remember that the result has to be very age specific. So when I see lymphocyte subsets in a 2-month child, that is not similar to what a 6-year-old child will have, right? So that's why this is very important to get verified in your lab. You can establish your own ranges in the lab. Now this comes the quality control. So what is lymphosum and T-sum? That is something internal quality we must follow in all our labs if you are not using it. So this is what will tell you that your process, your acquisition, everything is correct. Now you are ready to report the lymphocyte subsets. That is what is lymphosum. It is a sum of T, B and NK cells. So that should lie somewhere between 95 to 105, and only sum of T cells should be the total percentage of CD3 plus minus 5%. So your normal control sample should have this lymphosum pass, only then you can report on your lymphocyte subsets. So the various pitfalls, again the platform methodology is different, sample preparation techniques are different, the gating strategy is different. So all these errors, they result in the different lymphocyte counts which vary from lab to lab. So let's see some case studies. So this is 40-year female diagnosed as rheumatoid arthritis. However, she was not responding to methotrexate, so started on rituximab treatment, and the B lymphocyte analysis was done after 15 days of the last dose. So we have proceeded with the singlets like in previous all topics we have seen. CD45 and now gated CD19 and CD3. So where are my CD19 cells? Are they there? Are they there? Be louder. You can see them? No, we can't see them, but the 4-8 component is absolutely normal. So this was the case of rituximab where there was complete deficiency of the CD19. But what about if my technician has missed putting the antibody? Is there a possibility in this still? Yes, I doubted it. That mistake can happen. So you should be again diligent. If need be, you want to repeat the test, you repeat, and better to put a cocktail of the antibodies so that none of the antibodies is by any chance missed by the technician, and more so when you are dealing with the B lymphocytes. So it is a limited panel which you are putting, and if the technician has forgotten to put the CD19, you are going to entirely miss the CD19 B lymphocytes. Similarly, this case also patient for liver transplant. So what are we seeing here? CD19, 20, they are there. But after giving rituximab, what is the CD19, 20? They have absolutely gone, right? So this is how we monitor. Now let's see another interesting case. 10-year female came with joint pains and rashes with itching. On examination, there was erythroderma, plaques, cervical lymphadenopathy, mild splenomegaly. So what is hemogram showing? TLC, leukocytosis. Along with leukocytosis, what is the eosinophil count? So it is high, normal, or what? Severe eosinophilia at times, okay, crossing more than 5,000. Skin biopsy was done to rule out cutaneous lymphoma. However, it came to be negative for cutaneous lymphoma. Now when we analyze the lymphocyte subset, what you are seeing here, these cells are what positive for? CD4, but they are CD3 negative, right? This is the normal helper cells which are CD3, CD4 positive. This could be your CD8 cells. So what are these cells? Again, you see CD5. So normal mature T lymphocytes should express CD3, right? Which is the normal T. But what about this anomaly? They are not expressing CD3. So here what we are finding is the abnormal T cells which are CD3 negative, 4 positive, 5 positive and 7 was also negative. Now unlike in B lymphocyte where you see kappa lambda, right? There it is easy when you say clonality is there. But in T lymphocytes you just have to see the abnormal expression of these markers on the various subsets. So diagnosis was the lymphocytic variant of HES. Of course the treatment is steroid and they can also progress to lymphomas. Now another case, 15-year female with cervical axillary lymphadenopathy, pallor for 9 months. There were no associated B symptoms of fever, weight loss, and she was also hypothyroidism. On examination there was lymphadenopathy and mild spleen, and there was past history characteristic of recurrent infections. So what do you see in hemogram? What kind of picture is this on the hemogram? Pancytopenia is there, right? So various differentials varying from tuberculosis, lymphomas, and why autoimmune disorder? Because there was one component of hypothyroidism was there. She was having progressive pallor for 9 months with no all other conditions like TB, malignancies, they were ruled out. So what was done in this case? Again a T lymphocyte subset analysis was done. So if you see the T cells now gated in CD4, CD8. So what you are finding, these are the, like I have told you, mature T cells. Remember they are either CD4, CD8, and if they are double negative, what are they supposed to be? Gamma delta. That's why I told you to recall that the normal circulation, if they are gamma delta, they are both CD4, CD8 negative. But are we finding here gamma delta increase? No, we are not finding it increase. And what we are finding here, increase in the TCR alpha beta, right? So that was the anomaly here. So it was the double negative T cells which were there, and this came to be case of autoimmune lymphoproliferative syndrome, another spectrum among the autoimmune anemias and the autoimmune spectrum. That is, if it is more than 1.5 of total lymph or more than 2.5 of total T, we make it a diagnosis of ELP syndrome. Now this another interesting case, 78-year female, she had fatigue, so clearly there was anemia. Along with that there was jaundice, and she was known case of diabetes mellitus, pallor icterus, but there was no organomegaly. So I'm sure the residents are encountering day and night in their labs. What do you think this is showing? CBC came as clotted sample. What are these? What are these? They are agglutinates, okay? So they are it may appear as a clotted sample, but these are the tiny agglutinates. If you see the hemogram, HB was 9.5, not following the rule of 3. What is hematocrit? It is just 2. RBC count is very low. MCH and MCHC not detectable. So once we see the smear, what are these? RBC agglutinates. So what we are dealing with? Elderly female with the agglutinates. So what is likely to be? Cold agglutinin disease, right? And then after your warm incubation we did, then again HB was recognizable as 10.2, the MCV, MCH, they started appearing, DCT was positive, bilirubin high, LDS. So clearly we are dealing with what kind of picture as cold type of autoimmune hemolytic anemia. So if you recall in CLPDs we have warm and cold, and in cold autoimmune hemolytic anemia the most common component which we miss or ignore in these patients is the presence of the clonal lymphoid cells, right? So when flow was done, so again the lymphocyte gate. So when the flow was done, so you see the B lymphocytes here. Now what is CD20? So they are both positive for CD20. You will agree with me or no? Both positive and both positive for CD19. But what is unusual thing is that in these cells CD20 is dimmer. So important in the lymphocyte subsets is not just one aspect that you are seeing percentage or the absolute. Sometimes it is the intensity of the expression of markers also give us a clue whether we are dealing with some abnormality or not. So they are clearly abnormal B cells, and when the expression was there, they were both 523 positive, 200 positive, and clearly you can see they have the kappa restriction. While if you will see the normal B cells with the normal intensity of expression, they are both kappa lambda positive. So this came to be the clonal B lymphoid cells, and though it's a part malignant, but yes, it's a part of the lymphocyte subset. So it was monoclonal B lymphocytosis with AIHA. So the patient was put on bendamustine and rituximab therapy and currently doing very well. So my take-home message is that, so these lymphocyte subsets are one of the most common assays, and they include T cell, B cells, NK cell, and we must remember their characteristic cell surface molecule at different stages of differentiation. They play a key role in diagnosis, treatment, prognosis. Again, very important once we are seeing is the clinical presentation. The lymphocyte subsets may change if the patient is on certain drug, or may change if the patient is having intercurrent infections, and age appropriate reference interval. So you should have a stringent quality control methods which you follow in your lab. But at the end of the day, I will still say that absolute counts are not comparable between the labs. So you should have to follow one specific criteria which you are following in your lab. So this is a brief history how B and T lymphocytes were discovered. So they were discovered in the reverse chronological order. That's why I thought it appropriate to put the history in the end and not at the beginning, because this was how they were discovered. So initially the antibodies were discovered. In 1948 it was found that these antibodies are produced from plasma cells, then B lymphocytes, T lymphocytes, and their crosstalk was also being discovered much later. And Professor Miller, he was the one who was a pioneer who studied about the B lymphocytes, T lymphocytes, and there was very famously said that there isn't a single advance in vaccine, immunotherapy, autoimmunity research that does not incorporate his thinking, and we are still using his thoughts, and we are still using the lymphocyte subsets in today's practice. So both Max Cooper and Jacques Miller, they received the famous 2019. So they were discovered much early, but they got recognition very late. So we should not be disheartened for all these years if we get recognition late. So just for the sake of audience, this is what? Artichoke. So can anybody give a clue? What is this and why it has been put here? So this is a very hard fruit. Okay, so Dutch, they brought this fruit to England in early 1948. It is said to be very hard. The petals, they are very hard, but what is the edible part is the hard part. Okay, so this is the most edible part. So there's a very specific technique to cut this fruit. So how the one goes layer by layer, and then it reaches to the heart of the fruit, right? So it is said that the eater must be equipped with strong front teeth and patience. So I sometimes find the similarity this with the lymphocyte subsets. You have to have a robust internal quality control, you have to have patience, and once you see the layer of CD3, CD4, then uncover the CD3, CD4 in various plots, and that is how you reach the conclusion about your case or the diagnosis. So that's all. Thank you very much for your patience hearing, and I want to acknowledge my colleagues, Dr. Ashish, Dr. Gurpreet, Dr. Lakshita Sarjana, who have really helped me in putting up this presentation with their various inputs, sharing of the plots. So they are all my colleagues from AIIMS, settled at various reputed institutes all over the country, and of course my residents and my assistant professor in MAMC, Dr. Neelam, who was kind enough to overtake the reporting from me from some days and gave me valuable inputs in putting up this together. So thank you.
Thank you, Dr. Prerna. It was indeed a very beautiful talk and explained in a very simplified way. I'm sure all the postgraduates and all the other younger pathologists must have benefited a lot from it. You really made it very easy to understand.
Thank
and I hope they go back and follow it in their laboratories and they find it as easy to work upon as you made it appear here today. Thank you. Thank you. Any comments from the audience?
So once again, making a lecture as complex as this in a simplified manner is what the chairperson said, and really I compliment you, because we know what lymphocyte subset is all about, and it really takes a lot of diligence and patience to set it up. So these are the days we're getting a lot of people on treatment with rituximab. It is not only our lymphomas or leukemias which are, you have neurological disorders, you have rheumatoid arthritis, right, where people are being given rituximab. And you'll be coming across scenarios where you'll be asked, can you tell us, is rituximab working or not? Dr. Prerna and I have been discussing this over the last 2 months. So Dr. Prerna, this is a this is not exactly a question because you know, I know the answer and,
And
you
you
also
gave me
know.
such valuable inputs which I was not aware before
Yeah, there's a
making
beauty
this
of this question
presentation.
because we both know the answers of this question. So that's the beauty of the
Right, sir.
questions. We haven't planned this question for the benefit of all of you. When you monitor rituximab therapy and you do a lymphocyte, would you like to do only CD20 or CD19? Before Dr. Prerna answers it. Have you understood the question? Anti-CD20, now monitoring whether rituximab has helped or not. If it has not helped, it has not helped. If after a certain time limit you want to do it, is it relapse? So will you monitor only anti-CD20 or you will monitor both CD20 and CD19? Yeah, so you can answer this.
So, sir, in this, though literature varies, but yes, both CD19 and 20 levels have to be seen because it may happen that it is still there on CD19, but if in that case your CD20 is absent, though that really means your rituximab has worked. So it is recommended that you should be putting both CD19 and 20 in a case when you are monitoring for the rituximab
this is a very important
therapy.
answer. So you are going to see total B cell depletion. So for that,
and of course, in the relapsee, once they start the rituximab therapy, we have to monitor over subsequent time. Like normally, what is the 1 gram of rituximab which is given in certain conditions after a span of 15 days. So after that, maybe 1 month time interval, we are going to monitor whether the rituximab has actually acted or not. And subsequently, over the varying periods of time, we see again either the B lymphocyte and in certain literature, even the memory B cells, right? So you remember the memory B cells. So if they are again coming back, so that may be a feature of impending relapse of the disease even before the patient has clinically relapsed. So that is the utility that you do it. You see the baseline, set a baseline, and then you monitor the subsequent development of the B lymphocytes or the memory cells or the intermediate cells. So as they will start showing up in your flow plots that these are again coming, so that means there is going to be impending relapse of the disease.
This is an excellent question. We need a cameraman. Itna question पूछ रहे एक photo भी नहीं लगा कोई. ठीक है? Take a nice photograph. Where's the cameraman? He's sleeping. Get him here. So we gave 1 gram infusion every 15 days. Now you will be getting this scenario, rheumatoid arthritis. So we give 1 gram of rituximab. You know, we give 2 infusions, I think, every 15 days. Right. And then the pathologist is asked to do a lymphocyte subset to find out whether this infusion has helped or not. So we are going to do not only anti-CD19 and CD19 and CD20, we are also going to do T intermediate cells and memory B cells. So what are the markers of a B intermediate cell, not T, B intermediate cells and B memory cells? What are the markers? Because you can now add it on to your repertoire of lymphocyte subset. So you would like to take that?
So that will be covered in the next talk, but yes, the memory B cells, they are, the memory B cells, they have CD27 expression, right, along with IgD and IgM. So there can be memory B cells which are class switched, or they can be unswitched memory cells depending upon the presence of IgM is there or not, IgD is there or not, okay, along with the CD27. So this is how subsets we analyze. I think this will be covered in the next talk when we'll be dealing more with the lymphocyte subsets in the
This will be covered.
CID.
So remember, in lymphocyte subset, besides doing lymphocyte subset for various conditions, you will be asked whether your rituximab has worked or not, whether there has been a relapse or not, and if relapse, what are the cells you do? I think it's good enough. Anything else?
Thank you.
Lovely.
Thank you.
There, you've broken everything. Yeah.
I just want to know that we encounter so many cases of cold agglutinin disease, and as you have already shown it, lymphocyte subset.
See, if the clinical scenario is like in this case, it was definitely साथ में there was an associated hemolytic anemia component also. Otherwise, you will find MBL in elderly population also. But if it is coupled with and they are not responding to any treatment, you must target the clone. So that can be put, particularly in the elderly with the full-blown picture of hemolysis also, right? Cold agglutinin may happen without any hemolysis, or it may be associated with hemolysis. So if the patient is not responding to the conventional treatment elderly, we should see for the presence of these clonal cells in the bone marrow.
If you look at the new WHO classification, they have
classified cold agglutinins into cold agglutinin disease and cold agglutinin syndrome. So you have to do lymphocyte subset and all, because if you have a monoclonal disorder, then it's CAD, otherwise it's CAS. So that is the classification change which came up in the new WHO.
Thank you.
Thank you so much, ma'am, for this interactive session. And may I now request Dr. Vijay Kumar to introduce our second speaker, Dr. Vandana Puri.
So, Dr. Vandana is actually, she has done her MD Pathology and DM Hematopathology from All India Institute, Medical Science, New Delhi. She's currently working as Professor, Department of Pathology, Lady Hardinge Medical College. She has, she underwent internal auditor and QMS training as per ISO 15189. She has co-authored book, Complete Review of Pathology and Hematology, One Touch Pathology and Textbook of Pathology. So she has actually, been part of a lot of books. Recently also, I think she has been involved in the recent advances, published 46 articles. And she is member of various committees and like IAPM, ISC, ISTM. And so now because without any delay, I would like to actually invite her for this talk. So Dr. Vandana, please.
Thank you so much, Vijay sir, for the kind introduction. And at the outset, I would like to thank Dr. Thakar and Dr. Mukta for inviting me for this session. Thank you so much. So my work has been done easier by Dr. Prerna by covering the basic lymphocyte subset. So today we are going to talk about flow cytometry based lymphocyte subset panel for PIDD. What is PIDD, by the way? Primary immunodeficiency disorders. Perfect. So first, before going to the topic, how many of you have or how many of you get cases of primary immunodeficiency in your institutions? Raise your hands. Okay. So to start with, the name of PID has changed and these are now called as inborn errors of immunity. So they are IEI now because they are heterogeneous defects of immune system. Now it is said that behind every disorder and treatment, it's your immune system that plays a role. So immune deformities can present either as infections or as autoimmunity or as autoinflammation, even malignancies. So the pointer is, what are the tools that you've got for the diagnosis? Because it presents with a plethora of manifestations and we are messing up these cases. By the way, how many of you can tell me what is the prevalence of IEI in the world? Forget about India, in the world. According to the recent guideline, 1 in 1200 patients have an immune abnormality, which we are not picking up. So the tools of the diagnosis is careful clinical history, hemogram, especially in cases like SCIDs, immunoglobulin levels, flow cytometry, and genetic analysis. Okay, so this is the tools that we have, and I'm sure upper 4 ones, that is clinical history, hemogram, flow cytometry, and immunoglobulin levels are present with everyone, right? So what are the warning signs of primary immunodeficiency? Whom to suspect? So these are called as 10 warning signs of immunodeficiency. Any person, any child presenting to you with 4 or more new ear infections, recurrent pneumonia, wounds are not healing, you have to give IV antibiotics for treatment of infections, any family history of primary immunodeficiency. So if any 2 of these warning signs are present, you should do a lymphocyte subset for these patients. So how do you classify PID or IEI to be sure? So everybody should know this, that there's we have IUIS society which defines immune deficiencies, and this update came in 2024, which upgraded the immune deficiency disorders in a very, very vast form. So I'll try to make it very simple for the postgraduates out here. So it's very easy to understand. To classify immune deficiencies, we will classify either as a defect in the number of the immune cells. Number matlab, so we have T lymphocytes, we have B lymphocytes, we have natural killer cells, right? So first, you just say it can be a defect in the numbers. Now, the simple flow plot if I am looking at, so very simple flow plot if you put, so this is there a laser here? Laser here? Okay. Okay. So first we have to see the T cells. Okay. So what do you see? CD3, CD4 T cells, CD3, CD8, CD8 T cells, then CD3, CD19, 19 positive are B cells, and what are NK cells? So CD3 negative, 56 positive are your NK cells. CD3 positive, 56 positive is your NK T cells. Okay. So NK T cells are also a subset which you have to classify. So these are basic lymphocyte numbers that you have to do first. Okay, okay. Right. Apart from that, there are two more set of cells that we should understand. Regulatory T cells. So regulatory T cells are the cells which basically suppress your immunity. Okay, perfect. Which suppress your immunity. And then we have follicular helper T cells. Anybody who can tell me what is follicular helper T cells? Anyone? So let it be an interactive session so you will understand it better. What is follicular helper T cells? Anyone? So they're T cells. Iska kya matlab hua? So whenever we make a germinal center is made up of dendritic cells, B lymphocyte, and then T helper cells which go into the germinal center to give antigen to the B lymphocyte. So they are called as follicular helper T cells. Okay. So these also need to be assessed. Okay. Now, once we know this basic number, let's come to a case, okay? A very simple case. So I come from a hospital, Kalavati Saran, which has a lot of pediatric patients coming in. So I've mostly put real cases so that you can understand how we investigate these cases. So this is an 8-month-old female who presented to me in PICU. She was in sepsis, patient not responding to antibiotics. So the clinician was saying patient is not responding, what to do? CBC came. And CBC showed WBC count was 13,000. As you can see, the absolute neutrophil count is 12,600. 8-month-old child. What do you think, is the CBC normal or abnormal? Come on, speak up. Abnormal, normal? Abnormal. Why abnormal? Why abnormal? She's in sepsis. Can she get neutrophilia? She's in sepsis. Can she get neutrophilia? Otherwise, the most common cells in the pediatric age should be lymphocytes. But she's in sepsis. Can she get neutrophilia? Yes. Yes or no? Yes, definitely. But what is the lymphocyte count here? Look at the lymphocyte. Absolute. 950 cells only. Okay. So whenever you have such patient, go ahead and do the immunoglobulin levels. So we did the immunoglobulin levels. Okay. As soon as we did immunoglobulin levels, we saw the immunoglobulins were below the reference range, markedly below the reference range. Once you get this case, immediately in our hospital, we are doing single platform analysis, which Dr. Prerna told. So this is TBK-NK enumeration by single platform. I'll show you the report also. The single platform covers CD45, 19, 3, 56, 16, 4 and 8 together in one go. So this is how the report comes like. So this is called 6-color TB-NK report, and it has the beads which Dr. Prerna showed you, and with that we get the absolute count of the cells here. So what catches your eye here? So look at this. These are CD3 cells. Okay. So you can see 4, 8. There is some 4 cells here, but you can see B cells are very nicely present here, but T cells are reduced and there is no NK cells. There is no NK cells. So when the report came out, we saw that lymphocytes were 871. We saw in the CBC also 950 cells only. So it's 871. And CD19 was 843 out of this 871. Iska matlab kya hua? So there's marked reduction in T cells and NK cells. Okay. So what is this? We know now this is probably this could be a case of SCID, which is presenting with T negative, NK negative, B positive phenotype. But my dear friends, we are dealing with PICU. We are dealing with sepsis. So sepsis patients themselves have a lot of immune abnormalities. So they can present with transient lymphopenias, and this is one thing which you will very commonly see in your practice. So are we dealing with transient lymphopenia or are we dealing with SCID? So here comes the role of further enumerating lymphocyte subset. So all of us know that T lymphocytes can be classified into CD4 cells and CD8. Till here everybody knows. Dr. Prerna also told you that always remember to highlight gamma delta T cells, which you can analyze. But we'll go further and we will further classify the T cells into further subtype. So first, naive T cells, okay. So these are very, very important. Naive T cells, remember always, so they always have two antigens on them, that is CD45RA and CD27. So they are always present. So CD27 is a co-stimulatory molecule. ये हर naive T cells में होता है, so that they can receive the antigens from B cells and antigen presenting cells. So this is a marker which is present when the T cells are naive, okay. But once they get terminally differentiated, now they don't want, they're retired. They say, I'm retired, I don't want any antigen from anybody. So I will lose my CD27. So they will lose their CD27. However, 45RA remains positive. Now we can have central memory and effector memory T cells also. So central memory T cells, memory ban gayi hai. So now they said, now we are memory B cells. So they will lose CD45RA, but still, they have the memory that I can respond to antigen. So they are also 27 positive, but 45RA they will lose. And effector memory T cells are ones which don't have, so they will say that, okay, I will not have 45RA, I will not have CD27 also. So these cells are very less in the circulation, nearly negligible. Okay, so that's a further division of the T subset. So obviously, my case, I had to see whether I'm dealing with SCID or transient lymphopenia, I had to report. So remember, whenever we have SCID, these patients usually have decreased total T lymphocyte, plus the naive T cells are also not there because it's a gene defect. So they don't even have naive T cells. Forget about becoming memory effector. They don't even have naive T cells. So when you don't have naive T cells along with absolute T cells, then you're dealing with the case of SCID. So we put flow cytometry, and in the flow cytometry, as always, we know. So what did we see? Sorry. Okay, so what did we see? Till now we have seen here. So the CD3 cells were very less, 19 cells were beautifully present. Here there were some CD4 cells which were present. There was no NK cells, there were no NK T cells, and you can see 45RA. This is 45RA. So this 45RA was present in your B cells, which I will discuss later. But look at the T cells. T cells were absent for CD45RA. Also CD27. So CD27 was present in B cells. Some B cells were positive, some B cells were negative. But T cells were completely absent for CD27 also. So these T cells were not having CD45RA, they were not having CD27. So what are we dealing with? This is a case of SCID. So the clinician asked me, ma'am, gene analysis kaun sa karaye? So can we save the cost? Rather than sending for whole exome sequencing, can we send a specific mutation here? So your flow cytometry also tells you which mutation the patient is suffering from. So if you get a phenotype of T negative, B negative, NK cell positive, that is neither their T, neither their B, only NK cells are present, then probably you are dealing with RAG1-2, Artemis or ligase 4 deficiency. Now your phenotype changes. Now you have T negative, B positive, NK cell positive. Again, you know that this is interleukin 7 alpha or CD3 epsilon chain defect. Now your defect changes to T negative, B negative, NK negative. All of you know this is most common phenotype of autosomal recessive SCID, that is ADA deficiency. So this is ADA deficiency or reticular dysgenesis. And what is the most common type of SCID? Anyone who can tell me? Which is the most common type? It is X-linked SCID, which is basically T negative, NK negative and B positive, which was our case, okay? So this is common gamma chain deficiency or JAK3 deficiency. So this was our case and we told the clinicians to do this. This patient came to me just yesterday. So molecular testing has been gone for this patient. So all of you, I can update you the report once it comes. Okay, so now till now you have studied the panel design should include T cell markers. What all did you studied? So when we talk about, abhi to humne sirf T and NK ki baat kari. So we studied CD3 should be there, 4 and 8 should be there. Also include 45RA and 27 to pick up naive cells, and HLA-DR should also be there to pick up activated cells. And NK cells we have discussed 16 and 56. So that was about this. So a very simple tube which comes up as Euroflow pi dot tube can be utilized, and the same markers which we discussed are there in this. See here, CD27, CD45RA, CD8, CD4, TCR, gamma delta. CD3 and CD45. Can you see? So this pi dot tube covers all the T cells which you need to know. Everybody clear till here? Okay. Now once we're clear, look for the NK cells, that is 16 and 56. So NK cells is also covered in the panel. Rest of B cell markers which we are going to study next. Okay. So let's look at one another case which came to me. So this was 1.5-year-old boy with pneumonia. Patient referred with persistent pneumonia, treated with 3 different antibiotics, not responding. X-ray chest showing bilateral lung infiltrates. Again, as soon as you do this, what do? Immunoglobulin levels. Get an immunoglobulin level, and they were far below the normal. So we did flow as always. So this, again look at this case here. So what did you see? You gated lymphocytes, okay. So T cells were nicely present here, but look at this. So we usually put CD4 and CD20 together in V450. So this is basically CD20 and CD19 B cells. You can see there is no B cells here. No B cells here. So when B cells are completely absent, so for T cells are absolutely normal, and here you can see some CD8 cells are increased than CD4, but there is complete absence of B cells, okay. So T cells were perfectly normal, NK cells were normal, okay, so B cells is absent. So are we looking at a case of Bruton agammaglobulinemia? Are we looking at a case of Bruton agammaglobulinemia? How many of you say yes? Raise your hands. Okay, how many of you say no? Raise your hands. How many of you say, मैम पता नहीं क्या है यार, जो आप बोलोगे मान लेंगे? Is it like that? Yes? Okay. So yes, so this was a case of agammaglobulinemia, but again this is a PICU patient. So always remember that agammaglobulinemias can be a transient finding in PICU patients. So it's always good to do BTK as a marker. So what is a Bruton tyrosine kinase? So there is deficiency of B cells. Most cases are X-linked. Bruton tyrosine kinase deficiency is there. So you should always do BTK in monocytes. Why in monocytes? आप बोलोगे मैम ये तो lymphocyte subset है, इसमें monocyte में क्यों कर रहे हो? क्यों? उसमें B cells तो है ही नहीं, तो किस में करोगे? So we see in the monocytes. We can even do it in platelets. So BTK is usually done in monocytes or in platelets because there are no B lymphocytes. Okay. So what will you see? So in a normal person, this is BTK which is present here, and in the this is control, and in the patient BTK is completely absent. Okay. So that is your Bruton tyrosine kinase deficiency. That is congenital agammaglobulinemia, and of course, always remember we can also pick up carriers from that. In carriers also the mother will be a carrier. So this is a Euroflow pi dot tube which you can see, which covers your B markers also, right? So let's understand the importance of why do we have IgD and IgM now in B cell marker apart from CD19. Okay. So now coming to the defect in the functions of the cells. So we have T cells, we have B cells, we have natural killer which we discussed. Now we are talking about the function, and when we talk about the function, you should understand B cell phenotype well now. So whenever we talk about B cell, everybody knows that B cells are 45 and 19 positive and 3 negative. Now we can have naive B cell. Naive B cell is the first cell which Dr. Prerna showed. Okay, सबसे पहले जो आता है. So naive B cell is ulta of naive T cell. Why? T cells have CD27 on them when they are naive. That means they are ready to accept the antigen. B cells do not have CD27 when they are naive. So naive B cells do not have CD27. What do they have? They have Ig, immunoglobulin M and immunoglobulin D, because these are the two first immunoglobulins which are formed. So we have IgD and IgM which are there. Okay. Whereas when they become memory T cells, ab sab kuch seekh liya, then they will acquire CD27. So B cells acquire CD27 when they become memory B cell, whereas T cells, when they have 27, they are naive T cells. So be very clear with this. Okay. Do not confuse this. Okay. Now we can have class switched memory B cells and non-switched memory B cells. Okay. So what are class switched? Class switch मतलब क्या होता है? Class switching होती है when the IgM से they start making other type of antibodies like IgG, IgA. So they will lose their IgM and IgD and they will start acquiring IgG. So memory B cells means M and D becomes negative. Okay. Once they become memory, they are trained, they are CD27 positive, right? So they are memory B cells. उसके बाद non-switched क्या हुए? Marginal B cells which are non-switched. Non-switched means M and D will be persistent. Okay. So M and D is persistent, but since they have gone to the marginal zone, so they have acquired 27. 27 positive only means naive B, 27 negative means naive B cells. Once they become 27 positive means they have learned, they have become memory or marginal. They are not naive anymore. Okay? Now, IgM only memory B cells, these are very rare subset, usually not present in the circulation. So for all practical purposes, what are you going to remember? Look at the flow plot. This is the flow plot which you can see. So here can you see? We have IgD and CD27. So first, IgD positive and CD27 negative. कौन है ये? CD27 is negative and IgD is positive. Very good. So they are naive B cells. Now they will start acquiring 27, but IgD is still positive. So what are they? Unswitched memory. Unswitched memory, right? Now they have lost their IgD, but 27 is positive. So what is this? Switched memory. Everybody clear with this? So that is how the B cells go from naive, unswitched, switched. Okay, everybody clear with this? So these three subsets should be seen in B lymphocyte to say that their function is proper. Now let's look at the case, which will help you understand it better. So this was a 5-year-old child presenting with recurrent diarrhea and cervical lymphadenopathy. Okay, so the immunoglobulin levels were done as usual. They were below the normal ranges. Viral markers was done and the patient was EBV positive. So the clinician said, oh, EBV infection है, इसके कारण ये सब हो रहा है. So आप रहने देते हैं. So we said, okay, कोई बात नहीं. Send a flow subset. We will just investigate the case. So when we investigated the case, look at this, what we found. So look at this. So all the cells were stuck here. Okay, all the cells were stuck here. So we did control and we did the patient. So in patient, all the cells were here. There was nothing here, nothing here. So all the cells were naive. All the cells were naive. What does this mean? That means switching हो ही नहीं रही है इस patient में. So can you tell me a disorder where there is no switching? Which is that disorder of B lymphocyte when switching doesn't happen? So this is basically a common variable immunodeficiency. What is common variable immunodeficiency? When B cells are there but they cannot change into plasma cells. So this is usually a defect of BAF. Okay. So B cells are there but they cannot switch into plasma cells. So B cells hai hi nahi. So pre-B cells aaye, they are not able to make B cells. This is Bruton agammaglobulinemia. B cells hain but आगे plasma cells नहीं बना पा रहे. So this is a common variable immunodeficiency. Is everybody clear with the linearity that we are going here? So this is your common variable immunodeficiency where they are just naive B cells. Now always remember, okay, so whenever we are looking at this, when the naive cells are increased and there is decreased memory switch cells, okay, so this is a common variable immunodeficiency, and in this case molecular testing was done which was positive for TNF-SR13. This is the most common defect in common variable immunodeficiency. Okay, so by the way, how many of you know this person? Guess. So a break time. Anyone? So I'll give you the clue. He diagnosed the first case of agammaglobulinemia. So his name was Bruton, okay. So he was a chief of pediatrics. He gave the first report of agammaglobulinemia which was published in Pediatrics in 1952. Right. Coming further now to the defects of innate immunity. So we are clear with the number defect, we are clear with the function defect. Now let's come to the defects in the innate immunity. So defects in innate immunity, I'll tell you with the cases how they will present, but just to tell you, so usually they have leukocyte adhesion defect, chronic granulomatous disease, Mendelian susceptibility to mycobacterial diseases, which is very popularly called nowadays as MSMD, very popular, toll-like receptor defects or dysregulation, immune dysregulation syndromes. So these are the two cases which you will commonly get in your routine practice. So I'll tell you with one case which we had. So this is a 1-year-old female presented with multiple recurrent boils, poor wound healing, CBC में persistent neutrophilia. Okay, so the patient, look at the WBC count here. It was 17,500 and the neutrophil was 13,600. Immunoglobulins were done normal. TBK NK was done normal. Everything was normal. Patient, the clinician even did the bone marrow examination saying that there is persistent neutrophilia. And so we said, itna neutrophilia, let's work up for leukocyte adhesion defect. So what did we do? So we did CD18. So usually we do CD11, A, B, C, and CD18. So what we see it in the neutrophils. So look at the normal population here. Normal, the red one is unstained, which you should always put. When we put unstained, that was red. Now, immediately as soon as we put CD18, it came out here, it was positive. But in patient, what did we saw? These were the neutrophils, and just at this level unstained came, there only the neutrophil peak was coming. So it was not having CD18. So there was absence of CD18 on the neutrophils. So whenever we have absence of CD18 on the neutrophil, that is very classical for leukocyte adhesion defect. So whenever we talk about leukocyte adhesion defect, we have three types of defect: type 1, type 2, and type 3. Okay, so like type 1 is a defect of beta 2 integrins, which is identified by CD11, CD18. Okay, so LAD2 is a defect of Cial-Lewis X, which can be identified by 15S, and LAD3, again we had a case. So this was also on platelet function test, it will present like GT, but if you do the flow cytometry, there will be absence of the antigens like LAD1. So that is your typical LAD3 case. Okay, so that is your leukocyte adhesion defect whenever a patient presents with persistent neutrophilia. Okay, so whenever we have persistent neutrophilia, always investigate for leukocyte adhesion defect. So how do we do it? So this is the procedure. How do we do this? So we do surface staining with stain lyse wash approach. We put the antibodies CD45, CD11B, CD11C, CD18. Now we have added CD11A and CD15 also to the panel. Test sample shows the absence of 11B, 11C and 18 on the neutrophil, and I've already told about three types of LAD. Okay, let's look at one more case. So this is a 2-year-old boy with pneumonia, past history of hospitalization with multiple perianal axillary scalp abscesses, culture from the pus showed staph. So clinician ने बोला staph infection बार बार हो जाती है इसको. I don't know why he keeps on getting boils again and again. But immunoglobulins are normal, TB-NK is normal. So what are we looking at? So immediately we worked for chronic granulomatous disease. So for that we do dihydrorhodamine test. Okay, so how do you do it? So basically we check whether the free radicals are being formed by the neutrophils or not. So we add a stimulator, that is phosphoryl PMA, phosphoryl myristate acetate, PMA, and once we do it, the neutrophils get stimulated. So if we see if they are getting stimulated, that means they are releasing reactive oxygen species. Okay, so that is how we report it as the median fluorescent intensity of neutrophils of stimulated to unstimulated, and this is popularly given in the report as NOI, that is neutrophil oxidation index or stimulation index. The caution, you have to do it in the fresh samples. Okay, so that is very, very important. How do we do it? I'm just telling you the assay setup, how we do it in our lab. So we take an EDTA blood, normal unstimulated patient 100 microliter, stimulated 100, patient unstimulated. So we need 4 tubes, 2 control की, 2 patient की. Okay, 4 tubes ले ली आपने. अब उसके अंदर आपने dihydrorhodamine डालना है 1 microliter in all the 4 tubes. After that you incubate it for 37 degree in the dark for 15 minutes and leave it. After that you add PMA 10 microliter. How do you do it? You dilute it in 90 microliter of NS 1:10 ratio में, only in the stimulated tubes, control stimulated and patient stimulated में डालो, फिर incubate करो इसको dark में, and then you lyse with the formaldehyde based lysing solution for 10 minutes, wash and acquire with the stopping rate of neutrophils minimum 10,000. That's it. Very easy test to do. All of you can standardize in your lab. So this is how the report comes. So once you do it on the neutrophils, look at this. This is the unstimulated neutrophils, and here we get stimulated neutrophils. That's a normal pattern. When we look at the patient, these are the neutrophils. Here, just as the level unstimulated comes, your stimulated is also coming at the same level. So what does this mean? So this patient has deficiency of FOX. Okay, so what do you understand by FOX? So chronic granulomatous gene is basically due to defect in FOX genes. So they are basically NADPH oxidase or phagocytic oxidase, and if you look at them, they can be X-linked or they can be autosomal recessive. So we have 2 subunits. The membranous subunit is 9122 and the cytoplasm is 47 and 67. So 70% of them, they are X-linked, okay, which have membrane defect, and others are autosomal recessive and they do not form reactive oxygen species. Have a very strong suspicion if the patient is presenting with recurrent abscesses. Okay. So this, can anybody tell me what is this? Again neutrophils, stimulated and unstimulated. Now you're getting 2 peaks. So what is this? Yes, Yes, very good. It's a carrier mother. So once you see a patient of chronic granulomatous disease, always call the parent, especially the mother, because majority of the mothers will be heterozygous. They will be carriers. So do it in the mothers also and don't miss them. Okay. So that is your chronic granulomatous disease, which everybody should be clear. So these are two important innate immunity defects which you should work up whenever you have these kind of patients. Now, this is another case which came to me in my reporting, I think 2 months back. So this was a 12-year-old female presenting with generalized lymphadenopathy with fever. CT neck, chest, abdomen showed multiple lymph nodes, mild hepatosplenomegaly. The patient was sick looking. Bone marrow was done, showed you hemophagocytosis. Anybody guesses anything? What are we looking at? HLH. Okay, perfect. Somebody says HLH. So as always, we will always torture our residents. Ward जाके देख कर आओ patient कैसा है और photo भी देख के आना. So the patient had silvery hairs. Okay, so the hair of the patient was silvery. So the pediatric resident also told me that somehow her hairs are silvery. She's just 12 years old. What is it? Absolutely correct. Very good. I'm so proud of you. This is Grisseli syndrome, right? So this was a Grisseli syndrome. How did we work this patient up was, again, as usual for the HLH, you will do your ferritin levels and triglyceride levels. It was high, okay? But we did a perforin expression. So I'm telling you the role of flow cytometry in such cases. So obviously HLH can be made either by the genetic diagnosis or by the clinical criteria. You should have fever, splenomegaly, you should have cytopenias, hypertriglyceridemia, hyperferritin, low fibrinogen, plus either you do soluble interleukin 25 or you do perforin assay. So perforin assay on the flow cytometry. So I'll just tell you, okay, hey, just a second. I think the slide itself is not coming. So there was a procedure how we do that. So perforin is basically cytoplasmic dye. So first you put all the surface dyes. After that you permealize it and put for perforin. Somehow the slide, I don't know, it's not coming. So how we do with this is, look at this. So basically you have to see the perforin expression in cytotoxic T cells. So you either see it in CD8 or NK cells. Both need to be evaluated. So what do? So first, your internal control is always your CD4 T cells, which are always negative for perforin. They are the internal controls. Okay. So what do? So CD4 cells ko highlight kar liya. These are your negative T cells, negative controls. Okay. Apart from that, we have T cells and we have NK cells, which we do, and we look at the perforin expression. So this is the normal control where you can see the perforin coming up nicely in the NK cells. Okay, whereas in the patient, if you do this, it will be negative. It will be negative. So the normal range which comes by flow in this, it's nicely NK cells can be enumerated. About 71 to 98% NK cells can be picked up on this test. Okay, it's a good test to do, but permealization needs to be done very nicely. So that is your perforin assay which needs to be done. So these were some cases which so this patient was RAB27A positive on molecular genetics, and that is how we confirmed it that it was Grisseli type 2. Perfect. Diagnosis by Priyanka and the team, right? Okay. So now what is the role of molecular genetics? You know, molecular genetics is the key for the diagnosis of immune deficiency disorders, but flow cytometry always helps you to work up for which immunodeficiency to work for. So that will always help you in finding the right point of testing. So if you look at the 2024 update of IUIS, they have updated classification with 555 distinct IEI conditions, 17 phenocopies, and 63 new identified monogenic disorders. There are also a lot of new genetic entities which has been added in the new IUIS category. So the list is going to expand as always. Apart from that, a lot of autoinflammatory disorders also came up, especially VEXAs, which needs to be worked up whenever you have a lot of cytoplasmic vacuolation in the myeloid precursors in the bone marrow. Apart from that, severe EBV infections could have interleukin 27. So definitely the flow cytometry is going to expand more and more in IEI. The take-home message is flow cytometry is an essential tool for the diagnosis of various PIDs. It's a rapid technique that provides diagnosis as well as exclusion of the specific defect. It's a very important guide for your molecular workup. Assessment of the lymphocyte subset, surface protein, intracellular function, and functional assay. Everything is possible on flow cytometry. We can standardize everything. So the point is, I would like to acknowledge Dr. Jasmita, who was my senior at AIMS, Dr. Shailaja ma'am, who gives me free hand to do whatever I wish to in the Hemat lab. Thank you, ma'am. And Dr. Sunita ma'am, who also was a mentor and a teacher in hematology, who is the current DGHS now. Thank you so much.
It was truly wonderful from all count. I mean, both from the perspective of the detailed discussion as well as, I guess, all the case discussion that she has produced. Just a small, before I put up this to the audience, we actually diagnosed Grisly syndrome very long back, maybe I was 2001, 23 years back. That time actually flow was not there at PGI Chandigarh. We actually took the help of EM, electron microscopy, and we could see the abnormal clumping of melanosomes, because there is a problem with the melanin migration also in the Grisly syndrome. That was the reason of silvery hair. So that, I mean, I'm talking of that time, but after a lot of water has flown, it's wonderful actually. And any comments or questions? Was it actually truly exciting from all count?
Fighting against time. It was a wonderful lecture, and I just discussed with Dr. Pati. So Dr. Prerna, where are you? And Dr. Vandana, you are both selected for a topic in the National Hematology Conference, Hematocon. ठीक है? यही topic आप लोगों को बताना है. Dr. Vijay Tilak, please confirm.
Thank you so much.
So we are going to discuss in executive body meeting, and the president, Dr. Sharmila Chandra, we were discussing. So she said we must have a lecture on PID. So this is an appropriate this thing, because both of you have synchronized so well. It was as if both of you are doing lymphocyte subset virtually. Very good synchronization, and I know you have gone through a lot of 1 month preparation to make this topic so successful. So big hand for both of you.
Thank you.
Good lecture, really. We can't really anything extra to add to it. But to say that the way you presented and the case-based discussion, actually it appears as if the investigations by flow of the immunodeficient disorders is really easy. Actually, what happens is really people are really gets afraid that these immunodeficient disorders are so vast, and so people don't really even try to do it. But I think the way you have talked today, I think a lot of people should take it up, because particularly the common deficiencies, that not that difficult as she has already shown. I think if you are just doing, if you have a flow instrument, it is such a costly equipment, and you are doing for leukemia, lymphoma, and we have these immunodeficiencies are occurring, and we are not investigating. Actually, most flow centers are not venturing, thinking that it will be very difficult. I think she has made it very easy for us. We understand it is so well. Thank you.
Thank you so much, sir. Thank you so much. Thank you. Thank you. Yes. So there's no cutoff like that, but cutoff basically has to be age dependent. So for every lab we have, so like we are trying to build our own pediatric age setups. So basically there is a very good publication by ICMR Mumbai, Dr. Umair and Dr. Manisha. They have defined the age dependent lymphocyte subset values for a pediatric age group, because for me, I deal with predominantly pediatric age groups. So, and that is a tricky one also. Adults, it's still easy. So they have defined the age group, the exact ranges for everything. So it's easier for us to cut off, to see with that cutoff. But majority of the time, whenever we are talking about severe immunocytopenias or IEI, they will have very, very severe deficiency. Like in our case, I told you 0.055. So it was absolutely low. And you should have a very high clinical suspicion. Agar kam hai, there's no harm in doing lymphocyte subset. It is actually no harm. You're not putting up any extra tests. These antibodies are present with you. So why not run it off? apart from that, the clinical manifestation is very, very important. If their patient is symptomatic, presenting with recurrent infections, why not? See, I'll tell you in the first case that I showed you, the one thing that you must have seen that T cells were definitely decreased, but there were CD4 cells which were present. So normally if you look at the classical SCID case, CD4 भी नहीं होते, but उसमें थोड़े से थे. So that when I read the literature, I found that this is actually a type of MHC1 defect. So they can present with SCID with CD4, which a small amount of CD4 can be present. So that is how you evaluate more and you read more and you find more. So that is what. So age dependent cutoffs should be devised for each and every lab.
I would like to add to that. She talked about the when to suspect immunodeficiency disorder, primary immunodeficiency, the modal score. She showed also the 10 points, the 10 scores which are there. That is very important. So you should follow that. So when you have a suspicion, then you can always go for a lymphocyte subset. Okay, so recurrent infections and all those. She showed that score. So
Yes,
that is very important.
The 10 score, the 10 warning signs.
I think it's a very valid question.
Yeah, truly. I think there may be some questions, but we can discuss it, during the lunch time because already we are getting late. Thanks a lot.
Let's welcome Dr. Rahul Bhargav. He's come all the way from Fortis. And he's going to give a talk to us on myeloproliferative. He's extempo, he doesn't show slides. बोलते ही रहता है. So he's from AIMS and he is the pioneer of the bone marrow transplant which we have done in the last 3 years. He's done 2,600 transplants till date. So we'll talk more about him later.
May I now request Dr. Shailja Shukla to felicitate our first speaker, Dr. Prerna Arora.
May I now invite Dr. Vijay Kumar to felicitate our guest speaker, Dr. Vandana Puri.
May I now request Dr. Mukta Pujani to felicitate Dr. Shailja Shukla, our first chairperson.
I now request Dr. Charu to felicitate our second chairperson, Dr. Vijay Kumar sir.
Up next, we'll be exploring the exciting world of regenerative medicine and stem cell enumeration, followed by stem cell enumeration by the CD34 ESIC protocol. To chair the session, may we please welcome Dr. Sumit Barak, Professor and Head, Department of Immunohematology and Blood Transfusion, ESIC Medical College and Hospital, Faridabad. Sir has had a very long-standing association with the ESI family. With numerous publications in hematology, Sir has contributed extensively in the field of leukemia, blood coagulation disorders, and multiple myeloma. Sir has also played a pivotal role in various projects like automation in blood banking, HLA lab, and the NAAT lab. He has been actively involved with regenerative medicine and peripheral blood stem cell transplant. It's our honor to have you here, sir.
It's a proud privilege to invite our second chairperson for this session, Dr. Bharat Singh, Professor, Department of Immunohematology and Transfusion, ESI, PGIMSR, Basai Darapur, Delhi. Sir has formerly been the Director, State Blood Transfusion Council, Government of NCT. Sir has also been Consultant Director and Professor, Blood Transfusion Services, GTB Hospital and UCMS Delhi. As an NABH assessor, Sir has assessed more than 100 blood centers in India. He has been bestowed with many awards, including the State Award by the Delhi government for meritorious service in the field of healthcare. Sir has been granted with numerous international fellowships, including WHO Fellowship, Hartford Medical Center, Connecticut, USA. So please welcome Sir with a huge round of applause. May I now request Dr. Sumit Barik to call upon our first speaker, Brigadier Dr. Tathagata Chatterjee.
No, sir, we'll give
you a mic, sir.
Hi. Well, it's really a big job actually to introduce Dr. Chatterjee here, because there is nothing which is not yet told to you. But there are plenty of other things which are there with me, working with him presently. It's definitely something which is beyond excellence. The entire thing what you are seeing is here, it is with me also, so I am not going to repeat all those things. What I shall be talking about, it is about today's topic which he is too much interested in. That is a subject of regenerative medicine. You know, the best thing with Dr. Chatterjee is this, that he is usually having a combination of two in most of the things. The man is a very good teacher indeed, no doubt about it. He himself is very good research scholar, one. Second, he is a combination of a hematologist along with a transfusion specialist. And both the posts he carried as HOD at different places, right? Now, combination of these two subjects has taken into a conglomerate of therapeutic medicine, or especially the biotherapies. The advent of biotherapy is again secondary to the development of hematology and the blood banking itself. So today's topic, what Dr. Chatterjee will talk about, is about the regenerative medicine and all those things which are especially important nowadays. And one of them is, of course, CAR T-cell therapy. So please welcome our most loved teacher and, of course, our HOD,
Thanks.
Dr. Brigadier Tathagata Chatterjee. Welcome.
Acha, thank you, sir. Wonderful. I mean, you're my senior. Dr. Bharat is my senior. Dr. Bindra is my senior. All of you are here. I started my career as an oncopathologist, worked 10 years as an oncopathologist from Tata Memorial Hospital, then got my DM in hematopathology. And of course, part of hematopathology is also transfusion. So I set up the Department of Transfusion Medicine in FMC Pune, started the MD IHBT course. And when I retired, I started the MD IHBT course here, did the stem cell transplant, pheresis, so many things. I mean, it goes on and on. But why have I selected this topic today for you is something different. I am not going to teach you anymore. Because 2 दिन से बहुत teaching हो रहा है, ठीक है? I mean, we are looking for lunch, right? And, you know, teaching, we get fed up, you know? So I'm going to tell you a story, ठीक है? I'm not going to ask you any questions. एक कहानी बताऊंगा आपको regenerative medicine. And I go back to 2001 when one of my very dear friends, I don't know, he never liked morphology, or whether the subject of morphology did not like him, I do not know. But he was very brilliant, ठीक है? He did his PhD also from AIMS, ठीक है? Today he left all this morphology, flow, gating, ये इतना चीज सब छोड़ दिया उसने. And he is a multi-millionaire, because of regenerative medicine. So what he did was, he went into regenerative medicine, he started learning about stem cells, he started marketing stem cells, he got trained in USA, and today he is Dean of Stempeutics in Bangalore. Sir, your student, Colonel P.K. Gupta. Brilliant boy, brilliant man, my senior. What I'm trying to tell you is, this is also a branch of hematology and hematopathology. We talk about hematopathology, leukemias, MRD. Stem cell research is a very, very big branch. Very, very big branch. It has got so much of potential. Plus, you can get rich also, right? So, as I said. So, who is this? We'll quickly go through it. It's a story, but I thought I'll not ask you, but then the type of teaching. This is Prometheus, right? So he was punished. Why? I'm going to tell you a story only. He stole from Olympus fire, and he gave the fire to humans. So this gentleman, who was the king of the Olympian gods, he decided enough is enough. Zeus punished him. So he set up his eagle on him. So see this? This is the eagle which is devouring Prometheus. And what happened? Regenerative medicine started. He didn't die. His liver started regenerating. Okay? Till the point Hercules, saved his life. So this is actually regenerative medicine. So in the 1800s, some cells were discovered to generate other cells. And then 1900, the first real stem cells were discovered. But it was, as Dr. Bindra is going to set up the HLA lab, Jean Duché, who actually first identified these HLA antigens. And the era of hematopoietic stem cell transplants actually is from 1959 to 1963. That's a time when, this is Jean Duché of HLA, got a Nobel Prize. But I'm coming to Joseph Murray, who was a very famous baseball player, and later on became a plastic surgeon. And he did the first renal transplant. And the gentleman on the right is E. Donald Thomas. Did the first allogenic transplant, bone marrow transplant in 1959. And he published that in New England Journal of Medicine. And this is the man who actually set the bone marrow transplant program running. And we are eternally grateful to E. Donald Thomas. Nobel laureate in 1990, edited the first 2 editions of the hematopoietic stem cell transplantation. He's one of the most brilliant men. He died in 2012, and he became the head of the Fred Hutchinson Center also. So that's E. Donald Thomas. You get these questions in quiz contests, national quiz mein, hum log iska photo dete, who is he? And no one answers. But the stem cell research actually started in Thomson's lab, the James Alexander Thomson's. He first isolated successfully a human embryonic stem cells. Okay? So all of you MD students will be asked, what are stem cells, what are totipotent cells, what are pluripotent cells. These are very, very basics, and then you get embarrassed when you can't answer it. Okay? So let's get the basic right. And these 2 gentlemen are the epitome of what stem cell research is all about. The one on the right is, yes, Dr. Bindra's favorite question, right? He has given this quiz, Dr. Shinya Yamanaka from Kyoto University. He reversed it. He got pluripotent stem cells, what we call the induced pluripotent stem cells, from adult stem cells, because there was so much of embargo of getting embryonic stem cells. So he started culturing these stem cells and induced the pluripotent stem cells in a reverse direction. So Yamanaka is one of the famous. So with this small introduction, we'll just come to the basics. What exactly are stem cells? They are undifferentiated cells. They have self-renewal property, and then they can differentiate into various types of adult structures. So this is not an agreed upon number of stem cells. This is one of my PhD students who has made it, and I'm wondering what he has done, but he's done a good slide. So what types of stem cells? This is all based on embryogenesis. The day 1 fertilized egg, the day 2 2-cell embryo. I'll make it a bit more interesting than what this cartoon is projecting. So these are the types of stem cells. So you must know a totipotent stem cell. What is a totipotent stem cell? What is a pluripotent stem cell? And what is a multipotent? These basic ideas should be known to you, right? So this is what totipotent stem cell. Each cell can develop into a new individual. Cells from the early stage, 1 to 3 days of the embryo. Whereas a pluripotent stem cells comes from the inner cell mass, which is 5 to 14 days old, the blastocyst stage. And the multipotent stem cells are from the fetal tissue, the cord blood, and the adult stem cells, right? So I'm going to tell you in short about the scope of stem cell research, right? A lot of things are happening in the multipotent stem cell research. So the most promising and proven application of stem cell therapy, of course, is hematopoietic stem cell, and that's why I introduced Dr. Rahul Bhargav to you. Dr. Rahul Bhargav has done 2,600 stem cell transplants, of which 54 stem cell transplants have been done in this very hospital in the last 3.5 years. So I, being a senior man, has been given the task to, be the director of this stem cell transplant. And during this procedure, I learned from Rahul as a hematopathologist, and all of you can do the same thing. It is one subject, hematology, right? Someone are pathologists, someone's a clinician. We speak the same language. That's why we have a department of hematology at AIMS, where we are doing both DM hematopathology and DM clinical hematology. We speak the same language, we support each other, and we also do transplant. So these are a few guidelines. We will not touch into this because we are all very, very hungry. But look at these various types of transplants. We have autologous particularly, for us, multiple myeloma, a real success story. We are now almost on the brink of curing multiple myeloma when we pick up these cases very early and give autologous stem cell transplant. We have almost 24 cases of myelomas in our hospital. We have undergone successful stem cell transplant, and they are free from disease for the last 3.5 years. So that's a big thing, from an incurable disease to something where we are giving them life and hope, and they're living, without any symptoms. So their quality of life is improving. So this is a huge story, and a government hospital like ours, who has done so many transplants, is indeed a very proud moment, right? Then we have allogenic. We have done so many allogenic transplants in this hospital. Acute myeloid leukemia from near death. We have seen cases who are they're gone, they're dead. The private hospitals charge you 60 to 70 lakhs. Here we're doing it free of cost, and we have worked up the cost factors to about 12 to 14 lakhs. And we have now given life to the AMLs who were just going to die. So long-term, 3 years without symptoms, AML, not a matter of joke. Aplastic anemias, you can imagine the amount of transfusions these patients are taking, so much of burden. Now they are transfusion-free for the last 3 years. So this is an enormous thing, and again, a big hand to Rahul, because I'm discussing this because, he's gone all over the country doing transplants, and he and I, we, ventured, the private government partnership, if you may call it. And I'm still learning the art of stem cell transplant from Rahul, because wonderful, 2,600 transplants for one individual, not a joke, right? So we have an age. So you all should, donate. You should get your HLA typed, and you should go into donor registries. And so that, the needies can, contact you, from a donor registry. Indian donor registries are far, far away from what the German donor registry is, or the USA is, or England is, we have to donate more and more. We donate blood, but when it comes to stem cells, our HLA is matched. We are there in the donor registry, but when they call us, we are shy. We don't want to give it. And I'm going to give you cases of patients who have come all the way from England to get that transplant from you, and the donor has not come, and the patient died. I'll give you those cases. So these are unrelated donor registry. You got the AIMS registry, you got the Datri, you got the Jeevan Blood Bank. Do search in the Google, get motivated. So this lecture of mine is not a lecture. It is motivating you youngsters to take up stem cell research, donate, get your HLA type match, and enter your name in these registries, so that you should, the 2 days back, where's Saroj? She's not here. We had a Gaucher's disease, and 2 of our, Dr. Barik, he's the head of the department, 2 postgraduate students, first years, they went and gave their blood and saved this child. You see, they're leading from examples, so you have to lead from examples. So get your HLA matched, go to the donor registry, and be proud to be a stem cell donor. Am I right, Rahul? Yeah. So this is Indian scenario. So this is Professor Nalini Ambadi, Stanford University का एक scholar. उसका HLA match हुआ. She was AML. उसका HLA match हुआ यहाँ पर आंध्र प्रदेश में. She came, but that guy didn't come, and she died in the next 3 months. She died. So these are sad stories. So get motivated. So this Rahul and I have done this. This is our stem cell lab, and of course the blood bank. The blood bank of our lab, my God, Dr. Barik is now the HOD. It is now an NABH accredited lab in a hospital of this nature. We are doing stem cell apheresis. We have got license for almost 18 products. We are doing therapeutic plasma exchange. And as stem cell developed and the transplant program developed, so various departments developed. So the blood bank developed, flow cytometry came, the microbiology department developed, the cyclosporine labs developed, everything develops when you have a mission. Our mission was to save our ESIC patients from disease. The cost, the exchequer was so much, 50 lakhs, 60 lakhs, ye dil mange more, 80 lakhs. We are doing that in 10, 12 lakhs and free of cost here from the department, So this is our various transplant outcomes. We have done cases in Hodgkin's lymphoma, multiple myeloma, aplastic, AML, CML, BALL, MDS, and of course PNH, which Dr. Shilpi is going to show you live gating and Dr. Mrinal has talked. PNH, we have cured PNH, 3 cases of PNH. Rahul, they are now transfusion free, thrombosis free, cola colored urine free. Everyone talks of cola colored urine these days. This beautiful lady is our topper in PGI Rohtak. She did her MD IHBT. Dr. Barik is a proud person. She does the flow and she's going to do the live gating. Where is she? Neha? There she is. Why do you stand up? Give her a big hand. That's Neha. Neha is going to show you the live gating of CD34 today under the guidance of Dr. Gurleen. Gurleen, please stand up. Gurleen was head of the Lal's lab and now she's in Vedanta, right? Great lady. So they are going to show you live gating of CD34, what is engraftment, what is the importance of having CD34. Rahul, kaan khich khich bunj butao CD34 ka count kitna hai, because low count and high count are both dangerous. So we're going to tell you all about that and Dr. Gurleen is going to discuss that, right? And this, of course, is a place where both Rahul and I are missing. This is the stem cell. This is what happens. Nimisha was one of the architects of the, Nimisha, stand up. People should show you. She was the original head of blood bank. She is now in GB Pant and now in Safdarjung, one of the most brilliant pathologists, and she set up the blood bank with her own hand. ये जो आप NABH आज बोल रहे हो, she was not there to receive the award because जब award मिलता है, जो असली लोग हैं वो नहीं रहता है. उसका posting हो जाता है. She is one of them. So she worked tirelessly to set up the blood bank with Dr. Ashim Das. Let's not forget the great man. Yeah. So these are all cutting edge technologies. Cryopreservation, Dr. Bindra, they have seen you already, but I would like you to stand up again. He's started the cryopreservation in our blood bank. Today we can preserve our stem cells and give it after 10 days. Rahul, yes. It's a great thing. We have done 3 cases of Hodgkin's, if you remember. Yes. यही cryopreservation के लिए 10,000, 15,000, 25,000, dil mange more. Corporate world can take anything. We are doing it free of cost. And it is a good technology which Dr. Bindra has implemented with Dr. Barik. So this is our preprint. We are desperately trying to get it to a print. Lancet has given us a preprint. So this was a stem cell experience of 35-day transplants. So we have a preprint in the Lancet. I hope it becomes a presentation worth this. Nimisha is our co-author. Rahul and I are there. Shilpi is there. Where is she? I don't know where she is. Okay, she must be busy. Another very active person. There she is, with her Meghla Chadar, right? Okay. So this is our CB and this is our NABH. I think I'll stop here because we want lunch. I'll not tell you anything more. Should I tell something more about stem cells? I'll stop here. Gurleen, it's your stage now. My talk was to motivate you. Please do your HLA matching. Donate to all these, donor registries which you have, and be proud that someone is going to get a stem cell from you. And when they ask, please come and give it. Thank you so much.
Can I ask request Gurleen to speak 10 minutes before you see it, just for the photo op session will be happening. I'll speak.
Oh, okay.
Okay, thank you, Tathagat sir. Thank you, everybody. I am Dr. Rahul Bhargav, and it has been a team effort to build up what we are today. I think this is one of the best places to have this model where you can serve beyond your corporate world for the people. 6 दिन पेट के लिए और 1 दिन आत्मा के लिए is the concept we run through. It's not only here, but also in Indore Medical College, Mahavir Cancer Sansthan, Patna, and Bikaner Medical College. So all these people are doing a wonderful job for giving a transplant free of cost, where people who can afford transplant, they can come to Fortis, but who cannot, We still have taken the technology to the next level of doing the bone marrow transplants. You have a presentation?
Sir.
Perfect. So I'm going to speak about. Just go. Oh no, I'll just speak 10 slides. Give me the. Do you have a?
Yes, there's a pointer.
Can you just. Okay, so I'm going to speak about myeloproliferative neoplasm. Very simple for all the pathologists. जब भी कोई WBC काउंट बढ़ा हुआ होता है वो सारा के सारे इन्फेक्शन नहीं होता. 5-6 मैसेजेस वेरी क्लियर हैं जिसको अपने को देखना है. WBC काउंट बढ़ा हुआ है. Think about myeloproliferative neoplasm and not only infections. Look at the peripheral smear. Peripheral smear से हमारे को लेफ्ट शिफ्ट अगर दिखती है, think about myeloproliferative neoplasm because that's the one thing which can actually make a difference. Second important thing, as we go around Uttar Pradesh, Bihar, Jharkhand, there are still places where we just do bone marrow aspirates and not bone marrow biopsy. We always have to do a bone marrow biopsy along with a bone marrow aspirate. That's very, very important. Please remember that without a biopsy, you cannot make a diagnosis of myelofibrosis. It is very, very important. As we embark upon this journey, there's a concept which we have been trying to propagate and there might be controversial, looks controversial today. But remember me, you will remember me in 2026 when this movement will come true. What I'm saying right now is we have to forget about the PCRs when what we said as multiplex PCRs for myeloproliferative neoplasm will be a history. So mark the day today, it will be a history and I'll continue to tell why it will be history is simple as that because if you have because if you have access to NGS, which is soon we are going to have the access to NGS, there are two things which happens with myeloproliferative neoplasm. It tells you the VAF, variant allele frequency, it tells you, which is a prognostication in itself. And second, it tells you the co-occurring mutations. And believe me, once 3 papers comes out in this year, you'll be surprised that we are harboring 3.2 times more mutation than our American counterparts. We have just submitted a paper in Lancet Southeast Asian Journal about 600 patient data on NGS from our own Indian patients, where there's a larger mutation base. Then there's a core binding mutation, which we were told it's a good risk marker. Unfortunately, it's a bad prognostic marker in Indian scenario because not more than 30% people survive. The reason for that is we have got more NRAS c-KIT mutations. And when we compare 260 patient data from a TCS database, which is from MD Anderson and MSK-CC, we have got 2.8 times more mutations. We are all sitting on a mutation burden which is higher than Americans and Europeans diseases of what we see. So we are embarking on this journey. We are saying there is no more utility of a PCR for diagnosing a myeloproliferative neoplasm. It's a myeloid NGS which might be costing anywhere between 15,000 rupees to 20,000 rupees is a worthwhile test because it will give you lot more information than the required. So this is where we are, correlation of diagnosis. Molecular anatomy has moved on from JAK to MPL, KLR. There's a lot of more mutations which we are going to remember. As you have been diagnosing on flow cytometry, there's an utility of AI which we are doing and more than happy to collaborate with all of you. The AI will be an integral part of our department now. We have just launched an AI club, which is doing is all these flow cytometry based patterns will be correlated by the mutations where we can do that. Second, the HPLC graphs will all be put onto a machine. There's a 5,000 ml learning which we have already done, which will be utilized in the district hospitals where a simple app, you screen the HPLC report, it will give you the answer as accurately as a human mind does. So that's a second project which is right now going within our department. So more than happy. And the third is the most ambitious one is to have a facial recognition for anemias. So if we can get through that technology of facial recognition, diagnosing anemia, that will be path-breaking. So we are looking forward to publish that by 30th of May. So let's see where we get through. But remember this ASXL1, TED2, DNMD3, these mutations, people, I'm telling you, 5% of people sitting in this room will have had these mutations. Above 40 years of age, I'm sure 5% people will have these mutations, and that might be the cause of your inflammation, that might be the cause of your cardiac problems or atherosclerosis or the way you respond to the disorders. So we are ushering ourselves into an entire new era of genomics which we need to propagate and understand. So this is where we stand. WHO criteria, as we all know, the most important thing is the biopsy is required. Of course, the presence of JAK2 is required. Leukocytosis is there. Anemia might not be attributable to other causes. But this is more important. The morphology remains the cornerstone. In spite of all the advancements, dear all, the biggest thing which has still not changed is the eyes of the pathologist. And if you have that beautiful eyes of Dr. Tathagat, you will always be there. That continues to motivate the people to come back with the slides to be seen by him. So I think that's the beauty of having a good pathologist and a good pathology eyes in today's world. So this is what important, and this is keeps on changing. Morphology, megakaryocytic morphology, since the Jasmita days, we used to remember, you can actually fall in love with the megakaryocytic morphology, and with the megakaryocytic morphology, train your eyes to predict diseases. Just see the morphology of a megakaryocytes and say it is CML, polycythemia and myelofibrosis. Keep yourself challenging every day to predict the diagnosis by just seeing the megakaryocyte, nothing else. No history, nothing. Just train your mind like an AI. You put a megakaryocyte, 1, 2 megakaryocytes, and it says CML with a 99% sensitivity. That's what I say. The beauty of a megakaryocyte is it can reveal so many things without going into the expensive modalities. So, pre-myelofibrotic progressive is less than overt myelofibrosis. Everything tends to come to us in the later stages because we are not aware of the things at this present moment of time. What is the main problems? Anemia, leukocytosis, thrombocytopenia, splenomegaly, extramedullary hematopoiesis, thrombosis, and leukemic transformation continues to plague us at this present moment of time. Symptomatic burden is insomnia, inactivity, body pains, fatigue, which continues to have a problem in the country, in the setup. I think that's very important. And these are the scoring system of knowing the NP and 10 scores, how bad or good you are. The most important thing is the DIPSS scoring system. And now there's a molecular DIPSS scoring system, which is the Dynamic International Prognostic Scoring System, where the cytogenetics continues to plague us. So if I have to ask all my pathology colleagues, all my learned colleagues, what is the percentage pickup of a cytogenetics, karyotyping? Anywhere, let's put it this way, 3 choices, 30%, 60%, 90%. What is your experience? You have been seeing plenty of karyotyping. 30 to 40%. 40%? So that's why we are trying to bring the low-pass WGS into the system, which will soon replace the conventional karyotyping. If we are able to get through these 200 samples of a low-pass WGS, by 2025 next year conference, we will say karyotyping is a history. Let's do low-pass WGS, which is the NGS, which is done at a low pass, which does not give you a coverage. It will replace with this 3-day genomics NGS, which we have right now, which is the world's fastest, has been able to replace the PCR. So we do not do AML PCR any longer. We just take a 3-day NGS, we take it, within 72 hours we get the results, and that's fastest in the country, fastest in the world. The only place which can give us faster than is for 24 hours is MD Anderson. The rest is we are the fastest in the world, 3 days rather than 3 weeks. The benchmark was 3 weeks and it has gone to 3 days. So this is myeloproliferative neoplasm. Prediction models in clinical survivals are all there. CALR genotype, the impact of progression to myelofibrosis is well known. The most important thing is just remember this high molecular risk, why these all get missed. So if in an academic center you are trying to publish paper, then you have to have a complete data. The PCRs are not going to give you these mutations, which predicts the lower survival, which means you have to do the bone marrow transplant early in these patients. Number of mutations composing the high molecular risk affects the survival in PMF. So higher the burden of mutations, higher the chances of your relapses and less of a survival. So PMF prediction survival curves have been utilized, and this is the conclusion I would say is worldwide being used. Symptomatology is relevant, phenotype driver mutation. Just remember this. The most important thing is just remember the last point, that we need not do the PCRs, we need to go toward the NGS, which costs 15,000 rupees, which is worthwhile for a patient to know their risk factors and design the studies for getting a bone marrow transplant done early. क्यों? एक simple example देता हूँ. अगर उसको ESI में bone marrow transplant कराना है और 1 मई को उसको पता चलता है कि उसको transplant की आवश्यकता है, तो वो 3-4 महीने भाग दौड़ के इकट्ठा कर सकता है. पर अगर वो 1 सितंबर को आता है, जबकि वो प्रोग्रेस कर गया और तब उसको ट्रांसप्लांट की जरूरत है, वो 3 महीने का टाइम पीरियड नहीं ले पाएगा. सो जब हमारे को व्यवस्था है, गवर्नमेंट हमारे को पैसे दे रही है ट्रांसप्लांट्स वगैरह के लिए, तो उसको लैग पीरियड है 3 महीने का. सो इसीलिए we have to plan these people early, develop the molecular markers on the flow cytometry. I would say implementation बहुत हुआ, अब बारी innovation की है. So go back and try to innovate with the newer markers of what you can do, what you can predict and can help in reducing the cost. So last final statement is test more, treat less is the mantra which we have adopted both at ESI as well as in the corporate hospitals, and we have seen a downward trend of $5,000 decrease in the cost of the bone marrow transplant by utilizing the team as well as these genomic modalities. With this, thank you everybody. It is not me who has done it. It's I always what represents the we, and thank you to Dr. Tathagat who encouraged everybody to innovate. That's the beauty of this man is he does not discourage, he innovates. And that's the thank you. Thank you.
Dr. Rahul sir, we'll take another minute of your time as we call upon Dr. Tathagat to felicitate.
So, we have out of time, that's why we are hurrying up. Okay? My lecture was 40 minutes, sir. I'll give that lecture, sir. I'll give it some time else. Because, very short, very short. That's because, we have to go for the live gating. So,
We have one more.
have a quick lunch and then.
We have a lecture.
Workshop class is 2 o'clock. सर ये कॉन्फ्रेंस को करने के लिए एक फोटो ऑफ सेशन था. हमारी जो टॉक थी वो जरूरत थी कि ऐसी कॉन्फ्रेंसेस आगे फंडेड रहे, इसीलिए भी बस बिल्डिंग पे बुला रहे.
उनकी टॉक तो होगी.
These are changing us to the beginning.
Yes, sir. Thank you. Thank you, sir.
We now move to the last talk of this conference, and for that, I request Dr. Bharat Singh, our chairperson, to introduce our second speaker, Dr. Gurleen Oberoi.
Thank you very much. At the outset, I thank Dr. Tathagat and his team for inviting me to attend this scientific session. Now I invite Dr. Gurleen Oberoi. She is Senior Consultant Hematology, Medanta, the Medanta City Hospital, New Delhi. She is ex-program director for fellowship program of hematopathology at National Reference Lab, Lal Path Lab, New Delhi. She is the faculty and speaker at various national and international platforms. Areas of interest are minimal residual disease monitoring, myeloproliferative disorder, neoplasm, plasma cell neoplasia, etc. She will be talking on stem cell enumeration by CD34 assays, protocol, and case-based discussion. Dr. Gurleen.
So I'm standing between your lunch, so I'll concise it as much as possible. At the outset, I want to thank Tathagat sir and the organizers for giving me the opportunity to speak on this topic. And to begin with, I'll be walking through the topic through introduction, characteristics of IDL 34 assay, the platform, the most important part, the processing and the gating, and we'll understand all of this through a case, and lastly we'll conclude with quality. So hematopoietic stem cells, as Tathagat sir talked about, the most important quality of these cells are regeneration, that is self-renewal, and they can differentiate into all kinds of cells. That is why it forms the basis of the stem cell transplantation. So how many types of transplantation you know? Allogenic and autologous. So what is the difference between the two? So the autologous, in which the patient's own cells are transplanted, and the allogenic, where the healthy donor is used. So there are some differences in the stem cell enumeration, in generation of these stem cells for these two types of transplantation, for the very reason. So usually in the bone marrow, it is 1 to 3%, while in the peripheral blood, the quantity of these stem cells is very less, accounting to 0.01 to 0.1%. For that reason, the mobilization of these stem cells has to be done to the peripheral blood, where the collection of these cells are done. And how it is done? It is done either by cytokines like GCSF or by post-chemotherapy. In cases of allogenic, sometimes plerixafor is also used. So why CD34 enumeration is important? Because it comes down to the point what these CD34 cells antigen is. So it is restricted and specific to stem cells and these early progenitor cells. And what are the sources? The bone marrow, the cord blood, the mobilized peripheral blood. And we have to understand that this is a rare event analysis. Why a rare event? That even after the mobilization, these cells are much less in comparison to non-specific stained cells. So we have to realize that the specificity and sensitivity and the accuracy has to be very high for this rare event analysis. And why it is important? What is the need to enumerate these CD34 stem cells? Because it impacts the engraftment. So coming on to the engraftment, what do you think engraftment means? So engraftment is when the those donor cells, donor or new hematopoietic cells, when they are transplanted to the patient's body, how quickly and how successfully it starts reconstituting the blood cells and start producing the normal blood cells defines the success of the engraftment, which depends on the adequacy of your CD34 in the CD34 positive hematopoietic stem cells in the final product, which is then transplanted in your patient. So it correlates with success of the engraftment, the optimal timing of apheresis, and it is a parameter of quality and adequacy of the transplant product. So coming on to its importance in pre-harvest, mid-harvest and post-harvest. So in pre-harvest, it can actually predict how much stem cell yield is going to be at the end of the whole process of apheresis. It optimizes the harvest timing. It tells us and guides the GCSF or growth factor administration, how much is needed, the duration and everything. The importance of mid-harvest CD34 enumeration is to assess the harvest progress. So whether any adjustment is needed or the parameters like processing volume, the duration are also determined by the mid-harvest CD34 enumeration. This mid-harvest is very institutional based. Sometimes it is done in some institutions, some time it is not. So importance of post-harvest CD34 enumeration, it is the final product from which the CD34 enumeration is done. So it is used for predicting the engraftment potential. It evaluates the quality and the final dose which has to be transfused. So why it is important? This CD34 positive cell dose, why it is important? Because we have to understand the ideal range 2 to 5 is there. If it is less, then the suboptimal engraftment will occur. And there will be delayed or failed engraftment. If it is more than 8, then there are chances of GVHD. So what is GVHD? What is the full form of GVHD? So basically, the T cells in the graft and the immune profile of the graft actually starts targeting the host. So that is what we want to avoid. So more than 8 in an allogenic transplantation can lead to increased GVHD risk. So it is much more important in allogenic transplant to not give the overdose of this CD34 positive cell. So coming on to the antigen antibody CD34, we should know about this because not all CD34 antibody detect all the CD34 epitopes. And it is amenable to digestion by neuraminidase or glycoproteases. So on this basis, it is divided into 3 types, class 1, 2, 3. So 2 and 3 are preferred antibodies because of their resistance to one or both the enzymes. So we have to be sure of the antibody which we are using, and for that reason the clone that detects all glycosylation variants is chosen, and a conjugation with the brightest fluorochrome excitable by argon laser is chosen. For that reason, BD stem cell reagent composition has the clone of 88G12, which is the class 3 one, which is resistant to both enzymes. Coming on to the evolution of the CD34 enumeration, the whole story started in 1985, where they were using only class 3 CD34 clones, and then CD45 was added in 1994, the viability dye was added in 1995. The original ESIC protocol, which we know was formulated in 1996, which was to begin with a dual platform. 4 parameters were used, forward scatter, side scatter, 34, 45, and it required isotype control. Later on, BD single platform TrueCon bead used system was introduced in 1998, which is the one which we are using right now. So, coming on to what is the ideal characteristic of CD34 enumeration assay? It should be simple, widely applicable, highly sensitive, as it is a rare event analysis. The accuracy should be high because we can't miscalculate or because the implications are very high. The bone marrow transplantation success depends on this accuracy. It should be reproducible along all the labs, and it should be rapid as it is done real time during the apheresis. So it has to be rapid. So depending on these characteristics, the ESIC guidelines were created and are widely used as standard protocol for CD34 stem cell enumeration. We have seen this in lymphocyte subset analysis also. There are 2 platforms, dual platform and a single platform. In dual platform, the TLC is calculated from the hematological analyzer and is used along with the CD34 count from the flow cytometer to calculate the absolute count. They are multiplied and the absolute count is calculated. So there are 2 systems which are involved, which is prone to more errors. That is why the next and the one which we use widely is single platform, in which the addition of fluorescent beads of known concentration is used, which allows for the absolute count calculation of CD34. How it is done? It is done by a simple formula of unitary method in which the fluorescent beads of known concentration is utilized for the calculation, and thus a single platform is used. One second. How to go back?
Of course, majority of this you are going to discuss in the workshop.
Yeah.
Right? Maybe one case.
Forward. Back.
Should we skip to that slide? We can also do that.
Okay, yes, sorry. Yeah.
Slide through the mouse.
Right. It's okay. Sorry for the glitch. So the single platform 34 enumeration requires the various antibodies, the fluorophores, and we have to understand that the gating strategy which is used, or the 34 positive cells characteristic which is used is 34 positive, 45 dim population, forward scatter low intermediate, and side scatter low intermediate. And this is the stem cell enumeration kit, which is widely used. Coming on to the sample preparation, the sample is received at lab, the particular subject, EDTA is the preferred sample, and the TLC is calculated. After that, the dilution with PBS is done to obtain a minimum 25,000. The target is 25,000 cells per microliter. Reverse pipetting is used. The dilution is done to get that cell count, and then the dilution factor is utilized for the calculation. The two things which are most important in the processing part is to understand that lyse no wash technique is used, and reverse pipetting is used for the accuracy of the pipetting. So this is the process which we will be discussing in the processing part in workshop. This is the automated procedure adaptation along with the processing. Coming on to the plotting part, the gating part, the first plot is total CD45, in which the gating is done to include all the CD45 positive events. Along with that, lymphocyte gate is also formed in this. The next plot is total CD34 plot, in which it is important that as we are using bright conjugate, so the delineation of 34 positive cells is separate and proper, and at least 100 CD34 positive cells are the target to ensure a 10% precision. Plot 3 is CD45 dim population for the CD34 events. The viable CD34 gate, the plot 4, is set on the basis of the lymphocyte population. The next is the beats count. The plot 6 is for debris and platelet aggregate, and the plot 7 is for the viable CD45. So to assess the viability, 780 dye is used, which is a nucleic acid dye, and it attaches with the GC content of the DNA. And for that to happen, it penetrates the cell. So for that reason, the live cells are negative for the 780, while we can see the viable cells are the negative ones. The plot 8 is viable CD34 events. So these 8 plots are used. So we'll understand this along with this case in which a 6-year-old 2 months male presented with pancytopenia. On aspirate, there was megacrucitic hyperplasia. On biopsy, there was a hypoplasia which was there. On overall, the patient was diagnosed as aplastic anemia. This patient had a matched sibling donor, and the transplantation was planned. The pre-harvest was done. The same gating strategy was used, and the stopping gate in our setup we use as 200 for the CD45 34 cells to ensure a proper number. And this particular formula is used for calculation of the absolute CD34 count from the beads. And we can see that the population hierarchy highlights the Boolean gating. So this is the formula we use, in which the X events are the bead events, while Y is the CD34, which you have enumerated at the graph. So mid-harvest was done, in which the same strategy was followed. The post-harvest showed 1930 cells per microliter, and the dose calculation was done using this formula. So using the bag volume and patient body weight, the calculation is performed, and the calculation came out to be this much. So what is the problem we can see here? Is it more than 8 million? So yes. So what can be the issue? In such a patient, which is allogenic transplant patient with more than 8 million cell dose, such a patient has a higher chance of developing GVHD, as we just saw. So what is the the next step? What can be done to avoid that? So either the splitting of the product is done, or post the transfusion, the clinicians plans T cell depletion by using cyclophosphamide and things like that. So coming on to the case, the final report was given as that this and the harvest sample, what is mentioned in the report is important: the absolute count, the count volume of the product, body weight of the patient, final dose. So everything is clearly mentioned, the ESIC protocol and the references. So this is another setups way of doing it, which is done in the in National Reference Lab, and this is done by clinical software of FACS, which is completely automated. So the gating and the calculation is completely automated. Low control, high control, and patient samples are run. So the clinical application I already covered. The quality assurance is very important, as we understood the accuracy is that important. So the internal control is low control and high control is used. BD7 color bead or calibrate beads. External equals, one has to participate in equals to know whether they are doing it properly. So CAP and ECONICAS offers that. The quality control in our lab, we follow this. BD system actually recommends for different flow cytometer, different setup beats and different quality control systems. And one has to actually read these manuals to realize that there are interference which can interfere in the test. So there are cases where, though rare, can have these interference in the sample. So if it is not correlating completely, go back to the sample, whether these analytes are deranged in such cases. So the problem in standardization is different antibodies are used, the heterogeneity of sample, lack of uniform gating, even though the protocol is in place, the lack of uniform gating is there. Accurate pipetting is a problem. Number of events to be acquired has to be uniform. So the last thing is the ESIC protocol. The protocol is there, but are we doing it correctly? To find out that in 2012, UK NICAS did the study. They gave 100 cases to everybody, and they found that only 43%, 57% were actually following the ESIC protocol, and the 43% were misunderstanding the protocol. So as we can see, the major issues were missing gate, gating on wrong platform, using wrong antibody, missing plot and gate, so and using different protocols. So it was inferred that very less number of the people are actually following the protocol. So the conclusion is, it is most important technique. Single platform analysis is very important, and the ESIC gating needs to be reproduced, and it needs to be followed properly by the complete understanding. Thank you.
Thank you, Gurleen, for nice presentation. I think the felicitation.
Yes.
We are 40 minutes short, 40 minutes beyond, not short, beyond. So we have finished this session in a short way because we are now going to give importance to the live gating after lunch. That's where you are going to learn. So too much of lectures is also not too good for you. Okay? So we'll come to live gating. And let's have the felicitation. And where's Dr. Mukta? Dr. Mukta is here. Okay. Jaldi se felicitation.
May I now invite Dr. Sumit Barik to felicitate our first speaker, Dr. Gurneel Oberoi.
बुला लेंगे तो आ जाएंगे.
इसका पासवर्ड क्या है? मैडम
May I now request Dr. Aniruna Dey to felicitate our chairperson, Dr. Sumit Barik.
I now request Dr. Tathagat sir to felicitate our chairperson, Dr. Bharat Singh.
To conclude the event, may I invite Dr. Mukta Pujani to please come up
Dr.
and speak
Mukta
a
is
few
going to
words.
give a small talk. She's our HOD. She's the dynamic person behind the scene. You have not seen her because she has been behind the scene. Give her a big hand. So over to Mukta.
I won't take much of your time because I know I am the only person between the lunch and you. So just this conference has been the brainchild of Dr. H.P. Pati. I'm very thankful to you and Brigadier Dr. Tathagat Chatterjee. So a big round of applause for these two for giving us the opportunity to organize such a conference here. And then I'd like to thank all our speakers and chairpersons, senior faculty, my teachers, and colleagues and dear friends, because the names of the speakers and chairpersons on the scientific program is the first step in making any conference a success. And now the showstoppers of any conference are the delegates, because the success of any conference is by the number of delegates we have and the footfall. So thanks to you for making this conference a success. Now I'd like to invite my team, because putting up such a show on the stage means a lot of people work backstage, which are unseen and unthanked. So I want all of you on stage. Just we'll take 1 minute of your time. Please join us. The two people who have worked tirelessly are Dr. Deepti Siddham and Dr. Shilpi. They're born with Dr. Tathagat and me for the last 2 months. And let me tell you, it is very difficult because both of us are perfectionists to work with us and bear with us. So thank you. Come in the center, please. They have been excellently supported by Dr. Charu Agarwal and Dr. Aniruna Dey, my young professors in the team. Please join us. Dr. Varsha Chauhan, Dr. Shruti Chauhan, Dr. Aparna. He's been the excellent MC of the event. Dr. Neha as well. Then the entire team who've been working at the registration desk, catering, everywhere. So please give them. I have a very glamorous and dynamic team, so they deserve a round of applause, please. Thank you very much, all of you. So we'll take a please. And also, we'd like to please have a feedback from all of you on all aspects of the program so that we can improvise in the next event. Thank you very much.
The life. You have seen singletons, gating. So I am that singleton among so many ladies, and the blood pressure increases. Self-made. Applause for our junior residents who are sitting behind. So we've got 3 seats every year for MD pathology. maybe this year further seats will increase. See, before they tell us, jaldi karo. So we have to go for lunch and Dr. Pati has taken a site.
फोटो भी नहीं खिंचवा रहा था मैडम मैं सो रहा था सिलेंडर सिर दर्द
Oh, man,
May we request everyone to please proceed for lunch. However, we have a lost and found announcement. Dr. Jyoti Rana, Delegate Dr. Jyoti Rana, I think you've left your badge and diary. Please collect it from the backstage.
See, we could recover at least 25 minutes.
Does anyone know Dr. Jyoti Rana? She'll be needing this pass for the lunch. Just ask. Let me just ask.